is fundamental now to gather the data, to assess the data, to use the data to make informed decisions. I want to commend you on the work that you have done and encourage you to continue in terms of the work that needs to be done going forward.
The National Health Research Conference, NHRC, is where science, innovation and policy meet to impact the health and well-being of the population. This transformative event has been helping to shape Jamaica's healthcare landscape for over a decade. Following its inaugural staging in 2010, it's the flagship platform of the Ministry of Health and Wellness, uniting government institutions, academic minds and the wider public to share groundbreaking health research that's pushing the boundaries of innovation and that can provide solutions to meet modern healthcare needs. The NHRC's key objectives are to facilitate the sharing of research findings from the various participating researchers, identify operational research with the potential to shape public health policy, and aid special discussions on the conference theme to drive actionable outcomes.
It's research that will have some impact on our operations, our guidelines, our policies. For example, we did COVID research and that helped shape our COVID response.
Since its inception in 2010, with a gathering of 80 attendees at the Pegasus Hotel in New Kingston, conference attendance has soared over the years.
The last conference would have seen 933 persons on Zoom and over 6,000 persons on social media. So it has grown exponentially.
The National Health Research Conference has seen stunning growth each year in the number and quality of research abstracts submitted.
When we started out, with a few abstracts that would have been submitted, up to today where we have a large volume in terms of poster and oral presentations. The growth still continues to where our numbers have grown, and I'm very proud to be a part of that experience.
The National Health Research Conference awards presenters for high quality research in 3 categories for both the oral and poster competitions. And these are Best Overall Presentation, the Most Impactful Presentation, and the Best Student Presentation.
The systems that have been put in place has grown in strength, and the conference has likewise grown. And so the journey continues, but it has been a good journey.
Till the next conference, every 3rd Wednesday to Friday in November, this has been our peek inside the NHRC, with over a decade of transformative research shaping a healthier future for Jamaica.
It is fundamental now to gather the data, to assess the data, to use the data to make informed decisions. I want to commend you on the work that you have done and encourage you to continue in terms of the work that needs to be done going forward.
The National Health Research Conference, NHRC, is where science, innovation and policy meet to impact the health and well-being of the population. This transformative event has been helping to shape Jamaica's healthcare landscape for over a decade. Following its inaugural staging in 2010, it's the flagship platform of the Ministry of Health and Wellness, uniting government institutions, academic minds and the wider public to share groundbreaking health research that's pushing the boundaries of innovation and that can provide solutions to meet modern healthcare needs. The NHRC's key objectives are to facilitate the sharing of research findings from the various participating researchers, identify operational research with the potential to shape public health policy, and aid special discussions on the conference theme to drive actionable outcomes.
It's research that will have some impact on our operations, our guidelines, our policies. For example, we did COVID research and that helped shape our COVID response.
Since its inception in 2010, with a gathering of 80 attendees at the Pegasus Hotel in New Kingston, conference attendance has soared over the years.
The last conference would have seen 933 persons on Zoom and over 6,000 persons on social media. So it has grown exponentially.
The National Health Research Conference has seen stunning growth each year in the number and quantity of research abstracts submitted.
When we started out with a few abstracts that would have been submitted, up to today where we have a large volume in terms of poster and oral presentations. The growth still continues to where our numbers have grown, and I'm very proud to be a part of that experience.
The National Health Research Conference awards presenters for high quality research in 3 categories for both the oral and poster competitions. And these are Best Overall Presentation, the Most Impactful Presentation, and the Best Student Presentation.
The systems that have been put in place has grown in strength, and the conference has likewise grown. And so the journey continues, but it has been a good journey.
Till the next conference, every 3rd Wednesday to Friday in November, this has been our peek inside the NHRC, with over a decade of transformative research shaping a healthier future for Jamaica.
It is fundamental now to gather the data, to assess the data, to use the data to make informed decisions. I want to commend you on the work that you have done and encourage you to continue in terms of the work that needs to be done going forward.
The National Health Research Conference, NHRC, is where science, innovation, and policy meet to impact the health and well-being of the population. This transformative event has been helping to shape Jamaica's healthcare landscape for over a decade. Following its inaugural staging in 2010, it's the flagship platform of the Ministry of Health and Wellness, uniting government institutions, academic minds, and the wider public to share groundbreaking health research that's pushing the boundaries of innovation and that can provide solutions to meet modern healthcare needs. The NHRC's key objectives are to facilitate the sharing of research findings from the various participating researchers, identify operational research with the potential to shape public health policy, and aid special discussions on the conference theme to drive actionable outcomes.
It's research that will have some impact on our operations, our guidelines, our policies. For example, we did COVID research, and that helped shape our COVID response.
Since its inception in 2010, with a gathering of 80 attendees at the Pegasus Hotel in New Kingston, conference attendance has soared over the years.
The last conference would have seen 933 persons on Zoom and over 6,000 persons on social media. So it has grown exponentially.
The National Health Research Conference has seen stunning growth each year in the number and quantity of research abstracts submitted.
When we started out, with a few abstracts that would have been submitted, up to today where we have a large volume in terms of poster and oral presentations. The growth still continues to where our numbers have grown, and I'm very proud to be a part of that experience.
The National Health Research Conference awards presenters for high quality research in 3 categories for both the oral and poster competitions. And these are Best Overall Presentation, the Most Impactful Presentation, and the Best Student Presentation.
The systems that have been put in place has grown in strength, and the conference has likewise grown. And so the journey continues, but it has been a good journey.
Till the next conference, every 3rd Wednesday to Friday in November, this has been our peek inside the NHRC, with over a decade of transformative research shaping a healthier future for Jamaica.
Good morning, ladies and gentlemen. Welcome to day 3 of the 16th National Health Research Conference. I am Dr. Kevin Goulburn, Director of Mental Health Unit in the Ministry of Health and Wellness. Thank you for joining us in the room and online. Now, this is the final day of the 16th Research Conference, and we are pleased to have you join us. Invite a colleague, invite a friend, as today promises to be a quiet and informative one. We'll open the conference proceedings today with a blessing. So I now invite Mr. Stephen Davidson, Director of Public Relations and Communications, to offer prayer.
Let us pray. Lord, we thank you for giving us this beautiful day. We thank you for bringing us to the third day of this conference. We just invite your presence to be here with us. We pray that you will continue to have your way. We thank you for all our presenters and presentations and all the proceedings that will happen today. We place it in your hands, and we thank you for continued success, and we ask for your blessings in Jesus' name. Amen.
Thank you, Mr. Davidson, for your asking for the Lord's blessing on today's proceedings. Now, this feature presentation is entitled Hurricane Melissa, Childhood Trauma. And we have distinguished guest speaker for that session, none other than Professor the Honorable Wendell Abel, OD, OJ. Now, he's a professor of psychiatry. He's also a Hubert Humphrey Scholar, a prolific researcher and lecturer who holds a master's degree in public health from Johns Hopkins University. He's a strong advocate for community mental health. Professor Abel is a member of the International Cochrane Mental Health Research Group, the American Psychiatric Association, and the Jamaica Psychiatric Association. Professor Abel has spearheaded several mental health policies across the region and has written several articles, academic papers, and case reports for government and mental health agencies. In recent time, Professor Abel has been very involved in the mental health and psychosocial response post-Melissa. So, ladies and gentlemen, please welcome to the podium Professor Abel to give his feature presentation, Hurricane Melissa, Childhood Trauma.
Morning, everyone, in room, online. Certainly it's a pleasure to be here with everybody this morning to share a few thoughts, and I say share a few thoughts. So we are here today in Jamaica, and it's the aftermath of Hurricane Melissa. And this morning I want to speak to the issue of childhood trauma, but also on reducing mental health impact in children. Now, let me start by putting things in perspective that, I sometimes engage in gardening, and I always admire farmers and gardeners when they have a plant. And I'm showing something here, which is a slide showing how plants are treated. They stake the plant, they protect the plant, ensure that it's stable. And it's because they want to promote healthy development of plants. Equally for children, children need, for healthy development, they need to be secure. They need to be in a stable environment, they need to feel safe, and they need to be nurtured. Safe, stable, secure. Remember that, 3 S's. Safe, stable, and secure environment. Now, we know that trauma disrupts development, and children are vulnerable to trauma. Not every child exposed will have problems. And the reality is that when children are exposed to trauma, it may affect their life trajectory through childhood, adolescence, and beyond, literally from the womb to the tomb. And when we talk about childhood trauma, there are many terms that are used. Probably one of the most popular one, maybe the most sexy one, is adverse childhood experiences, which we refer to as ACEs. But we also use terms such as childhood adversity, early adversity, trauma, childhood stressor, childhood maltreatment, childhood harm, right? But I'll just refocus on the adverse childhood experiences. And they emerged out of studies done in 1998. And the study shows that adverse childhood experiences are common and linked to health outcome. And this study was a groundbreaking study which changed the narrative in terms of mental health and trauma. And when they did this study, they looked at the original 10 ACEs. And these 10 are, in purple we see abuse, physical, emotional, sexual abuse. 3, orange, neglect, physical, emotional, and neglect. And on the right we see, in green, experiences such as witnessing domestic violence in the home, loss of a parent due to death, abandonment, migration, drugs, alcohol use in the house, in the home, mental health issues in the household, having a family member who has been incarcerated. These were the original 10. And I'll come back to that and link it to a note on hurricane. And what the studies have shown is that ACEs are linked to 5 of the 10 leading causes of death globally. Yes, we talk about chronic diseases. There's a link between ACEs, trauma, and chronic diseases. Premature mortality. What we find is that people who've been exposed to a lot of ACEs actually die 20 years earlier. And the risk for health outcomes increases with the number of ACEs. So the more ACEs you have, you're exposed to, the greater your risk in terms of the negative health outcomes. And for example, if you have 4 or more ACEs, from the list we showed, there's higher rates of stroke, heart disease, diabetes, lung diseases, and many others. And 4 more ACEs, 15 times increase in the risk of committing violence, and lots of mental health problems like suicide, alcohol, depression, post-traumatic stress disorder, and anxiety. Now, the original study didn't account for all the causes of trauma. They listed 10, and they didn't look at enough on mental health issues and didn't establish causation. Now, today, we've now expanded the list of ACEs, and I'm highlighting here there are other individual factors, other family-related factors such as migration, and in red, I'm highlighting climate-related natural disaster, and this is where Hurricane Melissa fits in. And we know that this is a hurricane that struck Jamaica in September last year, Category 5. It caused widespread destruction, devastation, dislocation, disruptions, distress, all of these, right? With profound impact on families and children. And this is one of the generated pictures that shows what happened in Westmoreland, right? But what we know, because the reason I'm discussing this is because hurricane is, of course, a trauma. It's a traumatic event, and we now classify it, incorporate it among the ACEs, the adverse childhood experiences. And how does this hurricane and the effect, the wide effect will have on children, that it could really result, like any form of trauma, growth delay, problems with attention, learning and memory, low academic performance, poor regulation in terms of their behavior, such as poor impulse control, behavior that is not properly regulated, so they may become irritable, or show inappropriate behavior. Also emotions that are also not regulated, so the child may throw tantrum easily and so on. And adverse childhood experiences, if not properly dealt with and so on, may also result in self-harming behavior such as suicidal behavior, alcohol, substance use, aggression, violence, and risky sexual behavior. Now, the question, and so as I said, hurricane is a trauma, now considered one of the ACEs. It's in fact what we refer to as a collective trauma because it affected almost everybody. Everybody in the room would have been impacted to different degree. Everybody online would have been affected by the hurricane, right? And you may ask, how is it then a traumatic event such as a hurricane or any of the other ACEs will affect individual. And I'm quickly going to touch on the whole concept of what we call toxic effect, how trauma affects the brain, and I'll be very quick because I know it's time is short. But, you know, we talk about quickly the acute stress response. So if you walking on the road and you see a pit bull, yes, initially you know what is going to happen. Heart is going to start racing, you're sweating, some people are smiling, and it may trigger what we call the flight or fight response, right? Many of us would probably want to run, yes, or we hide behind a tree or something like that. And that's the acute stress response, which is protective. But if, for example, a child, and this is in the context of probably any sort of trauma they may be experiencing. So let me take, for example, a child who probably, as a result of the hurricane, there's overcrowding at home and many persons in a room, and the child goes home every night, yes? And that pit bull is in the bed with the child, yes? Then what will happen is the repeated stress is going to cause what we call a toxic stress response. And it will result in the release of chemicals such as cortisol, adrenaline, and other chemicals in the brain. And the toxic stress is really prolonged, repeated exposure to any sort of adverse childhood events. And usually the individual doesn't recover. No, but you may say, but the hurricane was a one-off event. Yes, it was. But as a result of the dislocation, house destroyed, overcrowding because families are now, many families living together, persons are still in shelter. Thank God most shelters are, we have very few, if any, children now in shelter because that was a priority issue that was addressed. The overcrowding, what we also refer to as the environmental stress that the children have to deal with, the impact on school and learning loss. So they're going to be ongoing traumatic experiences as a result of the hurricane. And then people tell you that with the recent wind that we've been having and rain, that has also triggered a lot of their emotional responses and traumatic experiences. So it's not only the hurricane, but also the effect of the hurricane which have caused prolonged, repeated exposure to trauma. And it, may result in toxic stress. And this is just showing, two slides, how on the left it's the normal brain, the right, you see the effect of the stress on the brain and the differences that occur. So prolonged, repeated stress can affect the brain. And I'm just going to go back to an early slide, which so what happens then with the prolonged repeated stress? This is the front of the brain, the frontal lobe, which is the thinking part of the brain. We know that with prolonged repeated stress, this part of the brain, the problem-solving part, is not working as well, right? And then inside of the brain, there's an area called amygdala, the alarm. A for amygdala, A for alarm. It's an alarm system that stress turns on this system. So that alarm is constantly on. That is why when the wind is blowing and the rain is falling, people are easily triggered because the amygdala, the alarm system, is constantly on because of the repeated stress. And the hippocampus, another part of the brain which is involved in memory and learning, it's like the file system. So it is also underdeveloped because of the repeated exposure to trauma and stress. So that persons have difficulty with memory, they have difficulty with identifying triggers and saying, well, this is not bad, this won't hurt me. You're walking through the park and then you realize that the pit bull is the owner is nearby and he's leashed. So is in leash, so he can't get away to hurt you. And then you say to yourself, oh, this is safe. But the person who is exposed to chronic stress because their alarm system is easily triggered, they're going to get very jumpy, very, very in an alert state to probably run and hide or whatever, yes? And so hope I've quickly just explained how stress really, acute stress affects the brain and how long-term stress can affect the brain and therefore the development. And where I'm going is how it will affect the children in the long run. So, how is it that children may be affected? So children may be affected in the early stages, I said, in terms of their learning and performance in school. You may begin to see behavioral changes. So the child who is usually quiet may become very disruptive in their behavior. The child who is usually active may become withdrawn, yes? And children may also become emotionally dysregulated. So they cry a lot, they become very irritable and so on. And I know I've touched on some of these, but just kind of repeating these things. It may affect their performance in school and so on. So these are some of the things that we have to look out for children in the aftermath of a hurricane. And then we have to remember, we're now in February, and the next hurricane season starts in a few months, probably a few weeks if you want to count it, right? So, you know, it just highlights how vulnerable we are to trauma and stress and so on. Now, having said all of this, how can we use all of this knowledge to protect our children in terms of children who've been exposed to stress? And I'm going to go back a little. And the research has shown us that there are certain buffering effects that will protect children from adverse childhood experiences and trauma. And in fact, one of the most impactful effect would be positive relationship with an adult, right? Whether the adult be a parent, a teacher, somebody in the community, but having a healthy, positive relationship is highly protective. And so we talk about ACEs, which are the adverse childhood experiences, and now we also talk about PACEs, the protective and compensatory experiences. And these are positive experiences that mitigate effects of the ACEs, such as the effects that may occur as a result of the hurricane. And these effects, these positive and protective effects will increase resilience, promote well-being, and of course reduce risk and so on. And we mentioned one of them being good parenting and so on. And of course, ensuring that, resource spaces like ensuring that children's basic needs are met, they're taught coping skills and so on. So get back to the question I raised. Can we use this knowledge to protect our children? And there's a lot of evidence-based intervention that show that home visitation, especially to vulnerable families, certainly can help. Positive parenting training, that's why we put a lot of emphasis on that. High-quality childcare and early years education. And programs, multi-component programs, are very protective of our children. And there's a famous Jamaican study that was done by a group out of the university many years ago, led by Sally McGregor, professor. And what they did in this study is highlighted in this study, what they looked at children who were undernourished, and they trained community health aides to go into homes, right, to visit these parents, teach basic parenting skills. There's nutritional supplementation, and the stimulation is what the community health aides would do, right? And so they had two groups of children who were undernourished. One group got the nutritional supplementation, and they had the home visitation and the stimulation. And the other group, all they had was just a nutritional supplementation, just treatment as usual. And what the study showed was 22 years later is that the group that had the extra bit, the home visitation, the stimulation, parenting training, they did much better in terms of, did better educationally, they were earning higher in terms of income, and they were less likely to be involved in crime, yes? And this became known as the the famous Jamaican study, the lessons learned is that when you have a good start, there's a strong foundation, and you get a great finish. Reminds me of Shelley and Fraser Price, right? When she gets out of that block quickly, you know she's going to have a great finish, right? But it also showed what I mentioned before: education, achievement, economic productivity, and better outcome in terms of health. Now, why am I saying all of this? Is from these lessons we've learned in the past. Today we're now looking at mental health and psychosocial support, especially post-Hurricane Melissa. And I know Dr. Goldburn and his team at the ministry with partner agencies like PAHO and other agencies are actively involved in strengthening the mental health system, and especially so for children. In terms of mental health and psychosocial support, because if we're going to lead our people out of recovery, we're going to have to take care of their mental health needs, especially children and adolescents. And so in terms of the mental health and psychosocial program that they're doing, you notice we have a pyramid, and at the bottom of the pyramid, a lot of emphasis is being placed on what we call basic psychosocial support. And I'm just sharing with you what is happening and what will continue, what we have to continue to do to protect communities, families, and children. And what is included in this basic psychosocial support is what we refer to as psychological first aid. I don't know if a lot of training has been done over the past years, and especially so since Hurricane Melissa, in training persons to provide psychological first aid. And everybody in this room can provide psychological first aid. Everybody online can do that. And so we're encouraging persons to train. It's not something that only professionals do. And we're also training persons, community members, family members, non-mental health professionals to train persons in another intervention, which is called Problem Management Plus, right? And just quickly, psychological first aid is really providing humane, practical support to persons. So we train you so you can go out there to provide support post-Hurricane Melissa, and we're continuing to do that. The Problem Management Plus is a little bit more involved, but you're trained to provide support to persons who are distressed. So people who are sad, anxious, having difficulties, just functioning and so on. They may need a little bit more intervention and so on. And a lot of emphasis is being placed on that. And I'm encouraging persons to sign up when the opportunity comes up to be trained in either psychological first aid or Problem Management Plus. But back to our children. We have to continue to support them, provide basic services, food, shelter, etc., provide psychological first aid for parents and teachers, and we've been doing that. And you will realize many organizations, regions, and ministry have been promoting the creation of child-friendly spaces, because in many communities, destruction and dislocation has destroyed their play area. I mean, even their homes, yes, been destroyed and so on. And so we have to create spaces for children. And also to ensure that we establish their routine and structure as quickly as possible. Now, just want to quickly highlight the study that we're supported. You might have seen that circulating on social media, that I got $5 million. I didn't get $5 million for myself because I almost had to go into hiding. But it was to fund this study. And the essence of this study, and I'm sure Dr. Goldburn is happy about this, is to train community health aides to deliver psychological first aid and Problem Management Plus. I mean, in much the same way that they were trained in that study many years ago by Professor Sally McGregor and team. We're doing a similar intervention so that they can strengthen our mental health services on the ground. You know, community health aides are, the program actually was developed in Jamaica many years ago through the Department of Community Health and Psychiatry, my department. And very good program, and the community health aides are hard workers, and they're considered to be the gatekeepers of the health services. They work and live in the community, and sometimes the first point of call in communities. So we're going to be training them to to be able to support the mental health and psychosocial support. But as I come to an end, it's just encouraging us that and reminding us that it's a time to implement trauma-informed practice. And I'll explain what trauma-informed practice is, but we need to implement it in our clinical services, our social services, human services, and schools. And what it is, it's really based on the premise. It's really services that recognize that trauma is common in our society, and that we need to be able to recognize the signs of trauma and to be able to respond to trauma better and ensure that we're not re-traumatizing people. And the 4 components of the trauma-informed services are: realize that trauma is common. In fact, 80% of children in Jamaica it is reported, have been exposed to at least one adverse childhood experience, right? And that is usually commonly in the form of violence in the home or community. So this is a high exposed society in which children are highly exposed to or exposed to high levels of trauma, right? And we have to realize that it's common and it's affect people and our children. We must be able to recognize the signs of trauma. I listed some of those earlier. And we must be able to respond to the trauma and better engage people and reduce traumatization. So, for example, you sometimes walk into emergency room and you see a child who might have attempted suicide. And that child is actually put in restraints, right? And literally tied to a bed. And the parents and the children will tell you that it's a re-traumatizing experience. And these are the things that we have to stop. That when children attend our health services, we ensure that their experience is a very pleasant one. They don't have to wait too long. They shouldn't show up and the doctor, the nurse is not there. We're not shouting at them and so on. We have to ensure that our health services, and especially those that provide services to children and adolescents, should be trauma-informed, and we make every attempt to reduce traumatization. And when these children come to us, a child who comes to us and is acting out and probably not behaving appropriately, we don't ask what's wrong with this child, right? But we ask what has happened to this child. Right? And I want to repeat it, that we should not ask what's wrong with this child, but we should ask what has happened to this child. So the next time you see a child acting out, a child withdrawn, a child probably daydreaming in class, right? Teacher shouldn't go over the child and take a strap. Well, they don't do it anymore and hit the child, right? But and ask what is wrong with this child not learning. But we should ask what is happening to this child. Maybe that child is going to a home where every night the pit bull is in the bed, right? And that pit bull may be an adult who is actually abusing the child, right? And we also need to remind, if we don't heal from what hurts you, if you don't heal from what hurts you, then you will bleed on people who do not cut you, right? And a lot of children are bleeding on people who didn't cut them. We see it with the high levels of violence in society, the problems in school, and it's because they're not healing from what hurt them. So if you don't heal from what hurts you, then you will bleed on people who did not cut you. And that applies for many of us also. And so, as I come to a close, I just want to say, let's pray for the children of Jamaica, and to remind us that, like the sun, we will rise again. And just to say to us, thank you very much for listening.
Thank you, Professor Abel, for such a comprehensive presentation, which was not restricted to Melissa, but it is giving information, practical information, broken down very simply for us to recognize that it's important for us to protect our children from trauma in our everyday existence. So thanks again very much, Professor Abel, for your presentation. I'm going to open the floor for any questions, whether it's in the room or online.
Good morning, everyone. Thanks, Professor Abel, for that interesting presentation. My question is, since we are having climate change and it is really noticeable, Category 5 hurricanes and so on will now become our normal. Since its implementation, our Project Management Plus pivoted to accommodate and better help our children, since they will be experiencing going forward many hurricanes.
All right, thanks for that question, and thanks for raising. It's problem management plus, but you get 2 out of 4, so don't worry yourself. And guess what? You give us the opportunity to just reinforce the name, problem management plus. But as I said, the psychological first aid problem management plus. These are techniques that fall under our mental health and psychosocial support program. Dr. Goldburn will tell you more about it. But what we're doing, you see, these are strategies that we use to strengthen the mental health services, yes? Because, we are resource limited. We don't have enough psychiatrists, we don't have enough psychologists to provide care. And so these are strategies that are promoted worldwide, not only in Jamaica, right? And we encourage people to be trained. But you ask, how will it help the children?
No, how has the project pivoted? Because you said it was implemented some time ago.
Yeah, but in pivoted, what happened post Hurricane Melissa, is that there was an increase in training and deployment, increase in training of persons, especially in psychological first aid, and deployment of these persons in the field. I think how many persons you trained, Dr. Goldburn, in psychological first aid? There's over 3,000? Over 3,000 persons were actually trained, and then they were deployed. And these are community members, teachers, healthcare workers. They are non-specialized mental health professionals. So you could have been trained in psychological first aid and be deployed out in the field. Anybody in this room was actually trained in psychological first aid? Some of you attended some of the training sessions, right? But we encourage, as many of us to be trained so that we can provide psychological first aid in our homes. Because psychological first aid is not only just about a disaster and about a crisis, somebody dropping dead in church or there's a motor vehicle accident, and we're called upon to be able to provide practical support to help this individual. So, yes, we need to continue the training. Yes, a lot of persons were trained, and yes, a lot of persons were deployed in the communities to help families cope and deal with the recovery. And yes, I'm sure Dr. Goldburn and his team will continue to train persons and deploy in order to strengthen community-based providers to be able to support mental health care.
Thank you so much. Looking forward for when that call comes again.
Talk to Dr. Goldburn.
All right, some questions online. If you are interested in getting your team trained or even teachers in the psychological first aid, how can that be arranged? And who do we contact? And is that a free offering?
You want to answer that, Doctor? And not taking over Dr. Goldburn work, he's a director.
Yes, it's free training, and if you call Ministry of Health, if you call us at 876-633-8259, then we can arrange the training. It can be done at your location, or we can arrange the venue for where we do the training. Because we have ongoing training, so if you have ongoing training, then we can invite you to be part of the training, or we can organize special training for groups of persons.
All right, thank you. All right, next question.
And if I just add, so some of the people we've trained are people like people within church organization, because every corner has a church, yes, and the teachers, lots of teachers and guidance counselors, and so what they need to do is to contact the guidance and counseling department in Ministry of Education or Ministry of Health, right? And I think also persons like shelter managers recognized need to be trained, and people working in National Housing Trust, people on the front line, JPS workers, anybody who, especially in this hurricane aftermath, just think about the people who are on the ground, yes? In fact, Yes, in fact, the firemen and police, in fact, you will remember there was an Observer article which spoke about this lady said that people were in the community distributing packages, right? And nobody asked her, how are you doing? Right? And that's the essence of psychological first aid. It's a little bit more than that, but it's about finding how people are doing, how they're coping, and providing practical support, right? And we did a very good job in the relief effort, but I think it could have been enhanced if more persons were trained in psychological first aid. Yes, question online?
Yeah, some more. Research project to train the CHAs in PFA and PM+.
Yes.
How will it intersect with the early stimulation training that CHAs have already been exposed to as part of child health services through MOH family health units?
Well that's the early stimulation project is for children, but the PFA is really more for adults and families, right? And the problem management plus is also designed to support adults and families. So the point is just adding another skill set to our community health aides who we respect, we admire, we know they're hard workers. But as was said previously, they live and work in the community. And the more skills they're training, the better they're able to do their work. Because they do it naturally. Somebody may have a problem and they see a community health aide at a bus stop and they walk up to her and they start talk to her, or and that is where that first contact occurs in terms of basic psychosocial support. In fact, I remember in my early career when I worked in St. Anne, one of the things I actually did was train community health aides in terms of being able to do some basic mental health tasks. And I was amazed at how quickly they acquired the skills and how effectively they delivered, because after a while they were interfacing much more with people in the community and even referring persons to me. So we find that when you invest a lot in training your community health aides, the returns are actually great.
All right, one more question. You focus on hurricane trauma. What of children exposed to crime scene?
Well, crime, exposure to crime, as I mentioned earlier, it's probably one of the crime and exposure to crime in the community and community violence is in itself one of the adverse childhood experiences, right? And 80% of children in Jamaica have reported in studies that they have been exposed to violence within the home or in the community. That in itself is an adverse childhood experience, and it is going to cause a long-term effect on children, emotionally, behaviorally, will result in learning problems and long-term mental health problems, this chronic exposure to crime and violence in communities. And the same applies. There's one slide I left out in terms of how do we deal with our children on an individual basis. And there are the 3 L's. You look, listen, and link. Every day you monitor your children. Look for signs, especially in this post-hurricane period. Look for signs of distress. If they're withdrawn, there's change in behavior, they're not performing as well in school and so on. And secondly, the second L is listen. So we look, listen, link. Everybody in the room repeat that for me. Look, listen, link. So we look for signs of distress, changes in behavior. We listen to them. Must create an environment in which children feel safe to listen. And we must link them to ensure that they're getting the basic support services. I'm glad Ministry of Education has made sure that schools are open so that they can link into their educational services. If they're having health or mental health related problems, we need to ensure that they are referred to appropriate services and so on, yes? So look, listen, link. Everybody, that's our responsibility. At home, in the community, in school, in church, look, listen, link. Yes, that's it.
Just
yeah.
one. Good morning.
Morning.
And thank you so much, Dr. Abel, for such a timely presentation. I am Karen Nelson, Regional Nursing Supervisor from the Southern Region. And you know, Black River
Yes.
was an area that was pretty much affected greatly. And I can see, based on how the presentation was brought forward, toxic stress on the brain of our children. And I see it so easy for our children to be, affected in such a great way. Even outside of the hurricane, a simple thing can cause a child to just go overboard. And I saw how the team responded. This is my personal experience now. I saw the team responding on the ground, and it was amazing. I saw how they actually implemented or initiated the PFA, the first aid, and I know the team as well came and they were very much involved and engaged with the problem, that one, PM Plus.
The PM Plus, right.
And
Problem Management Plus.
Problem Management Plus.
Yes.
And
I usually struggle with it too, and sometimes it's a PMP, and people say you have to be careful. But it's Problem Management Plus. Yes.
Right. But I think this is a very, very, very strong initiative that has been implemented in the field. And I see where the parents, the teachers, and the rest of the community are really embracing it. And so I am just putting a plug in that we continue to strengthen this program, because it can only be a plus or addition to our healthcare delivery system.
Thank you for that feedback from a senior nurse. And I think we should give Dr. Goldburn and his team a round of applause, right? Obviously, the program is working in the field, Dr. Goldburn, and you should be proud. And I must also recognize Dr. Christine Robinson from Medical Director for your at the National Council on Drug Abuse, because I know Dr. Robinson and her team also have been doing a lot of work in that area on the ground. So you all must be complimented, because obviously the mental health team is obviously trying to do its best in terms of mental health and psychosocial support for the entire population, but also for children and adolescents. Having said that, just want to encourage us again to ensure that if you're not trained, be trained, so that you can be a provider in psychological first aid and problem management plus. And I just want to say to everybody, thank you and have a wonderful rest of the day in your conference.
All right.
One more question? Oh, by popular demand. One more question.
Yes, just a quick one. Any practical suggestions on how to use PACs to support adolescents during this time, especially those going through exam years and pivotal milestone years?
Well, I think for people who are trained, I mean, as we said, the psychological first aid just provides some tools to engage persons who may be distressed and so on after an acute crisis. Yes, so yes, it can be used, but I think there's also another program which involves training more suitable for persons over the age of 9, your children, adolescents, the older ones, which is psychological first aid for children and adolescents. And what they do in that program is actually train peer leaders in schools and in the community to be able to work with children and adolescents, children over the age of 9. And I'm sure that is a program that will be introduced in Jamaica on a wide scale.
All right. Someone asked, is it the same contact number for training for PM Plus?
Yes, it's the same contact number. Dr. Goldburn, your programs are very popular. All right, so that's it. All right, thank you very much and have a wonderful day, and thanks for your participation. Thank you.
So it leaves up for me to just thank Professor Abel for leading our guest presentation this morning. Even though it was Hurricane Melissa, it was focused on, but we went wider than that, and we're hoping going forward that the opportunity that Hurricane Melissa caused to have us have psychosocial support teams within our different parishes will continue going forward, as we're always going to need that support for other situations that may come about, not just hurricane, but other disaster, whether it's man-made or natural disaster. So thank you again for joining us in this feature presentation.
Let me just acknowledge, that's Paulette Smith. Yeah, she's the director of National Council on Drug Abuse. My favorite person. You would have welcomed, and we're glad that you're here. Your organization is doing an excellent job on the ground.
And we'll break now for a coffee break. Have a good coffee break. Thank you.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated. Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at the age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated. Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at the age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. the pain, the struggle. I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated. Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom And as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Good morning, everybody. I trust you have been refreshed. It is my pleasure to be able to welcome you back to day 3 of the 16th National Health Research Conference. I'm Paulette Spencer-Smith, and I'm the Executive Director for the National Council on Drug Abuse Department in the Ministry of Health. Welcome again to presentation number 2. Today we have an esteemed guest speaker for this session, Dr. Kristen Robinson-Barrett. She is a consultant psychiatrist and the Director of Treatment Services at the National Council on Drug Abuse. And she currently oversees the treatment team, which is responsible for the management of individuals with substance misuse disorders. Dr. Kristen Robinson-Barrett has several years of experience in community mental health and specializes in the diagnosis and management of mental and emotional disorders. She strives to provide high-quality, evidence-based care and collaborates on the development of programs for substance use prevention and mental well-being. Ladies and gentlemen, please help me to welcome Dr. Kristen Robinson-Barrett.
Good morning, everyone. Thank you for having the National Council on Drug Abuse come to present on this very important topic. We appreciate this opportunity. This morning, we'll be speaking about substance use disorders in Jamaica, and I'm hoping that it will be a helpful and informative presentation for everyone. So let us begin by understanding what a substance use disorder is. It is a mental health condition, and it's characterized by a problematic pattern of use of a substance that leads to adverse physical and behavioral consequences, and it would persist despite these negative consequences. Substance misuse is the use of a substance in any manner or situation or amount or frequency that should cause harm to the user or those around them. Now, if we have prolonged, repeated misuse, this can lead to a substance use disorder, but we'll go in further detail about this diagnosis. Before we get into the Jamaican context, we need to understand the global context for substance use. Looking at some global statistics from the World Health Organization, we know that the most common substance use disorder worldwide is alcohol, and this is followed by nicotine and then other illicit drugs. There are 400 million people living with alcohol use disorder as of 2024. And there are 1.2 billion people worldwide using tobacco. 1 in 5 adults worldwide are addicted to nicotine. And there are greater than 100 million people worldwide who are vaping. In terms of the United Nations World Drug Report of 2025, this is looking at illicit drug use. So this does not include alcohol and nicotine. That as of 2023, there are 360 million drug users worldwide, that's illicit drugs, and 64 million of those have drug use disorders. The most commonly used drugs worldwide are cannabis and opioids, followed by amphetamines, followed by cocaine and ecstasy. And of this, 1 in 18 females are receiving treatment and 1 in 7 males are receiving treatment. So we see where access to treatment for substance use disorders is a critical gap. In terms of the impact of substance use disorders, we have to know that there's a complex relationship between substance use, drug-related harm, and socioeconomic status. And we find that persons of lower socioeconomic status are unfortunately disproportionately affected. There is a significant impact on mental health. So we have co-occurring mental health disorders in up to 50% of persons with substance use disorders, and in some populations as high as 75%. And that's what we call dual diagnosis. there is a significant impact on the outcomes for major non-communicable diseases as well. And there is an increased risk of acquiring viral infections due to injectable drug use, but also due to risky practices. Substance use is also a major contributor to injuries in terms of traffic and violence, and it is a leading cause for global burden of disease in youth, and it also has a significant economic and healthcare burden. So when we look at how do we deal with substance use disorders, the Substance Abuse and Mental Health Services Administration advocates for prevention first. So prevention means evidence-based prevention programs and policies that we have at every level of the community. And then we need to have strong social connections that promote emotional well-being and resilience. And this is how we help to prevent substance misuse, especially in youth. We also have treatment, of course, which means that we can effectively treat substance use disorders with behavioral therapies. And there is a role for medication as well, particularly when it comes to withdrawal syndromes, which is very common in the use of alcohol and opioids. And we will need medication for the treatment of some of the comorbid psychiatric conditions. And then we have to advocate for recovery, which means maintaining remission when it's achieved. And this is through social networks and programs. I want to go through some categories before I do some concrete definitions. In terms of the categories, you have to understand that hazardous substance use is a pattern of use that increases the risk of harmful physical or mental health consequences to an extent that warrants attention, but there is no overt harm. An episode of harmful use is when there is an episode of psychoactive substance use that has caused significant harm to this individual's physical or mental well-being or harm to another person. And then a harmful pattern of use is when there is this sustained pattern that causes clinically significant impacts to their health or to those around them. Now let's look at some definitions. We would have heard some of these terms, but what do they mean? Substance misuse is harmful or hazardous use of psychoactive substances, as we saw, based on the way you use it, the quantity, or the method. And we saw what harm and hazard meant previously. We also know the term addiction. So the American Society of Addiction Medicine defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction of these circuits can lead to biological, psychological, social, and spiritual manifestations. And this would be reflected in the person pathologically pursuing the reward of this substance or needing to get relief by using the substance. And so they end up with actual executive dysfunction, and that causes the 3 C's, which is craving, compulsion, and consequences ignored. What separates these terms? So if we can think of it, misuse is actually an action, addiction is a physiological state, and substance use disorder is a clinical diagnosis. And so that is what we'll focus on. So looking at substance use disorder and its criteria, this is according to the DSM-5. Just to note that the previous criteria from the DSM-4 TR would distinguish between abuse and dependence. We no longer do that. It is just a single, one single spectrum-based diagnosis at this time. In terms of the substance use disorders that DSM recognizes, it recognizes alcohol, caffeine, in fact, cannabis, hallucinogens such as PCP and LSD, inhalants, opioids, we know heroin, fentanyl, sedative, hypnotics, and anxiolytics, so our benzodiazepines such as Xanax, stimulant use disorders, so cocaine and amphetamines, and tobacco, and then we have a category for other substance use disorders that do not fall in this list. Looking specifically at the criteria for substance use disorder. So we have to know that it is a problematic pattern of substance use that leads to clinically significant impairment, and that is the highlighted point, that the person has clinically significant impairment as manifested by at least 2 of the following criteria over within a 12-month period. So this individual may take the substance in larger amounts or over a longer period than intended. There is a persistent desire or unsuccessful attempts to cut down. They spend a great deal of time trying to obtain the substance or recover from it, and they have often have cravings, and these are impulse control issues. They also have recurrent substance use that results in a failure for them to maintain their major obligations. They have continued use despite having persistent or recurrent social problems. and they have important social or recreational activities, they give them up or reduce them because of the substance use, and that would be considered their social impairment. There is also recurrent substance use in situations where it's physically hazardous, and there is substance use despite knowing that they have a physical or psychological problem caused by the substance, and that's what we consider risky use. And then we have our pharmacological dependence, so that is tolerance, which means that the individual needs higher amounts of the substance to achieve intoxication, or they have a reduced effect or a diminished effect when they continue to use the same amount. And then they have withdrawal, which is manifested by characteristic withdrawal syndrome, which may be different for different substances, or they have to take the substance or something closely related in order to relieve the withdrawal symptoms. So for example, for alcohol, they may have to take Xanax or a benzodiazepine to have a similar effect. We also specify if the person is in early remission, which means that they had previously met the full criteria and now they don't for more than 3 months, but less than 12 months. And in sustained remission means that the individual previously met the criteria, but they no longer meet it, and that's for greater than 12 months. This remission does not include cravings, however, because it's recognized that cravings will continue even throughout remission. And we do specify if it's in a controlled environment, so that means the individual is in hospital or a residential facility. We code based on the severity. So someone has a substance use disorder that is mild if they have 2 to 3 criteria, moderate if it's 4 to 5, and severe if they have greater than 6 of the previous criteria. And opioid use disorder has specific specifiers. Now we want to look at the risk factors for substance use disorders, which is important because we have to mitigate these risk factors to see if we can reduce the risk for an individual. So in terms of biology, we know that genetics play a significant role if you have a family history of substance use disorders. Cocaine and alcohol are the most heritable substance use disorders. Cocaine has about 70% heritability and alcohol has about 50 to 65%. The presence of comorbid psychiatric disorders, of course, as we said, there's a high comorbidity and that increases your risk for use. Behavioral and impulse control issues in childhood increase your risk for substance use. Having a chronic medical illness, especially a painful condition, as we know there would be a risk for opioid misuse, there would be a risk for use of cannabis, alcohol, and so on. The properties of the drug taken, so the more highly addictive the substance, the more likely there is for a use disorder, and the early age of first use. In terms of the psychological risk factors, we look at traumatic experiences, including our adverse childhood experiences, or ACEs. We also have poor coping skills or a lack of parental involvement can affect an individual. In terms of social and environmental risk factors, so we know cultural norms play a large role. We know that culturally acceptable use is going to drive young people. Peer pressure, social stressors of any kind, so job, financial, and so on, having issues with employment, issues with housing. Advertising can also drive use. Social influence and social media are major contributors now that we have to be aware of. Having ease of access and having limited educational opportunities. And just a brief word on dual diagnosis. So as we would have already seen, that it is a substance use disorder that co-occurs with a mental illness, and the risk is up to 70, there is a 75% occurrence of this. Common conditions are depression, anxiety, post-traumatic stress disorder, schizophrenia, bipolar disorder, ADHD. And it is a complex relationship between substance use and mental illness, because we know that you can either have mental illness coming first, leading to substance use to cope, or you can have a substance use disorder first, and then it leads to the development of a mental illness, as we see with cannabis-induced psychosis, or cocaine-induced psychosis, or affective disorders. And the other complexity is that there's a common genetic, psychological, and social interplay, so the adverse childhood experiences are risk factors for both. So it requires successful treatment would require the management of both conditions. Now we get into the Jamaican context. Taking a look at the statistics from the 2023 National Drug Prevalence Survey, this was conducted among 12 to 65-year-olds, and this found that 60% of Jamaicans, this is in the past year, had used alcohol, 20% had used cannabis, and 17% had used tobacco. And I want to highlight how that differs from the global statistics, in which nicotine would have been ahead of cannabis. Higher rates of use are seen in males. 17% had used alcohol in a harmful manner, and 66% of past years cannabis users were at risk of misuse. That means intense use. And cocaine use was prevalent in less than 1% of the population. This figure allows us to see across the parishes what was found. So some of the things that were highlighted were that Trelawney, St. Anne, and Kingston were of concern for alcohol use. Kingston, Trelawney, and Clarendon were of concern for cannabis use. St. Andrew, Trelawney, and St. Anne were flagged for nicotine use. Harmful alcohol use was of greatest concern in 25 to 35-year-olds, and cannabis use had the highest concern in 18 to 25-year-olds. The average use use for males was 16, and for females was 18. Some other things that were noted in terms of the changes from the 2016 to the 2023 study, we saw that harmful use of alcohol remained relatively the same. However, daily use of tobacco had increased, and we also saw where high risk of ganja use had increased as well, and edible use had also increased. And now we're going to look at the treatment trends from the National Council on Drug Abuse over the past year. So looking from January to November of 2025, these are the persons coming in for assistance for substance use disorders. And we're seeing that, generally speaking, we're looking at the 200s to the 300s in terms of numbers. This is across the island seeking help. But we see that there is a fall off towards the end of the year, in October and November, which may be considered to be associated with the passing of Hurricane Melissa. We saw a total of 849 clients over that period and did 3,205 sessions. Here we are summarizing the substances that were used. So we're seeing where cannabis was the #1 drug of impact. And so despite the fact that alcohol is the most prevalent in terms of use, the most commonly used substance that persons came in for treatment was cannabis. Then followed by tobacco and alcohol. So cannabis was responsible for 60% of all cases for treatment. Now of concern is vaping. So it's showing a growing presence in that after tobacco and alcohol, we had vaping, and it was responsible for more cases than for cocaine, prescription drugs, and mushrooms altogether. And just some emerging trends. Again, the vaping is coming out as a concern. Synthetic drugs such as Molly and ecstasy. And we have new psychoactive substances. So these are posing a significant challenge because they are easy to synthesize, they're difficult to detect, and there's a lack of regulation. So we're seeing that over 1,000 individual NPSs were reported to the United Nations Early Warning Advisory in 2024. And this is causing a mix of substances, so polysubstance use, and the concern for the use of synthetic opioids in these compounds. So we have our early warning system on drugs. This was launched in February of 2024, and it is an institutional network of approximately 40 multidisciplinary focal points. That's from public health, law enforcement, and it's tasked with issuing alerts about these psychoactive substances. And it develops a rapid and effective response to maintain a surveillance system in the island for any of these substances that may be detected. And just a brief word on treatment as we close. We know that we have to start with management of withdrawal, so we are greatly concerned for opioids and alcohol especially. Therapy is the mainstay of treatment for substance use disorder, as well as medication. Some of the commonly used treatments, so we have individual and group therapy, and we have motivational enhancement therapy, CBT or cognitive behavioral therapy, dialectical therapy, contingency management, family therapy. And just a look at some of the treatment services available in the island. So we have inpatient and residential facilities. So we have the Addiction Treatment Services Unit at the University Hospital, Richmond Fellowship, formerly Patricia House, Teen Challenge. These are residential facilities. Public hospitals would only do acute management. So that means for acute withdrawal states and for comorbid psychiatric conditions. And then we also have private care. In terms of outpatient care, of course, we have the National Council on Drug Abuse, we have ATSU again, and we have our mental health clinics across the island, as well as private care, which includes Narcotics Anonymous and Alcoholics Anonymous. And just a word on the vision of NCDA. So NCDA strives relentlessly for a drug-free Jamaica, and that means eradication of substance misuse. And we also have an area for mental wellness promotion. Some of the pillars for NCDA are prevention, of course. So we design and deliver evidence-based, culturally relevant prevention programs to foster general mental wellness practices. And we also have public education and awareness. So we educate the public about substance misuse and its dangers, as well as mental wellness promotion. We have treatment and rehabilitation. So we facilitate and implement treatment plans and counseling with our counselors and psychologists for those affected by substance misuse. And we also have research and monitoring. So we conduct and monitor and analyze the trends in the substance use in Jamaica, which we would have seen, to guide program development and inform policy. And we also are involved in advocacy. So in conclusion, the impact of substance misuse is cross-cutting and it is complex. And it affects mental health, non-communicable diseases, crime, and overall productivity. And so we have to address this issue using an intensive multi-pronged approach and interventions in multiple settings across multiple groups to help us to prevent misuse and to maximize our outcomes. And so I leave you with the fact that addiction recovery is more than just stopping drinking or using a substance, but it's an ongoing process of growing and healing mentally, emotionally, physically, and spiritually in terms of helping persons across the island. Thank you.
We are going to invite you now to be able to get clarity on any of the areas that you would want to be able to talk through. Are there any questions online or in the room? You need to come back, Doc.
Question. Is the 2023 drug prevalence study a representative sample?
I can answer, yes it is. You can call the NCDA and we can actually give you a copy of the study for you to be able to look at the processes behind the survey. But yes, it is. It was conducted through the University of the West Indies. Go on.
Yes, there were 4,995 respondents for the survey. That was a sample.
All right, next question. Are there any psychological disorder associated with edible use? How much is too much?
So the important thing about edible use is that it is going into your gastrointestinal tract. So when you smoke cannabis, you're inhaling it. When it goes into your gastrointestinal tract, that's a large amount of absorption. So you'll find that the effects of edibles is going to be longer than inhaled use. And so that's much harder for you to control. So certainly the psychological effects are exactly the same as consuming it by any other means. And you're not really sure how you're going to respond to it. And once that has absorbed into your system, you are going to have to be dealing with its effects until it has passed. So the psychological effects are going to be the same. And we're talking about cannabis edibles, right? So we know that the risk is going to be all the same intoxication signs and symptoms, and potentially the risk of emotional changes or changes related to psychosis. So, having delusional thoughts or hallucinations can happen. You can have psychotic type symptoms coming from use in that manner. And as I said, the concern is the fact that you have ingested it.
All right, next question. Since the decriminalization of small amounts of cannabis in Jamaica, has there been any observable impact on substance use disorder rates, particularly in relation to tourism-driven demand?
Okay. So what we found would have been in the 2023 survey, which showed that the 66% of cannabis users being at risk for a substance misuse disorder. So what it was showing was that there was more intense usage from the persons who were using. So since decriminalization, persons who were using more intensely and were therefore at a higher risk. So that's what we were noticing.
All right, next one. Is the growing use of cannabis as alternative and pharmacologic applications impacting its misuse, especially in younger persons or the younger population?
Well, I can't speak specifically to the thoughts of young people on that, but we do know that cannabis does have medicinal uses, but we have to know that there are different parts of cannabis. You have the psychoactive component and you have CBD, and CBD certainly has a role in the medical field, and so we can't deny that. I think the importance is the education of the young people for them to understand the circumstances under which it is safe to use, and we want that to be under guidance of a medical professional, of somebody who can give you appropriate dosing for those things. And it's not just a case where, well, I have a condition and I'm going to take up cannabis and self-medicate. We want it to be under guidance for those beneficial properties.
All right, thank you. No more questions so far.
There's one here.
Good morning. Thank you very much. Very informative and interesting. Just a quick question. Under the listing of residential care,
yes,
you had Teen Challenge, Richmond.
Richmond.
But you also at the bottom, private care. Do we have homes in Jamaica that specialize for this type of intervention?
We do have nursing homes that would admit for certain mental health conditions and substance use. I wouldn't expound on that because I can't speak specifically to any private facility and its, its level of care and so on. So there is no specific private facility that I'm able to list, but we do know that there are private homes that manage dually diagnosed persons. I should backtrack to say that Professor Abel and so on also does have his residential facilities. My apologies. But outside of his, I wouldn't speak to any other specific ones. There are ones that I can't speak to, but we know there are residential facilities. Ferdy's house is listed, yes.
Ferdy's house.
Yes.
But that, for me, that kind of raises some amount of alarm because there should be some, I'm not sure the regulations go for the others. I understand the ones that are run by professionals.
Yes.
Right? So is there any type of regulatory body that looks at the ones that are not run by?
So there are standards of care, right, for residential facilities that they should be abiding by. That the ministry collaborates with the National Council on Drug Abuse so that we can abide by these standards of care. But then there are, of course, other regulatory bodies that are involved in the checking and the assessment of these. And so it has to be, various groups coming together to regulate them. So we have the standards of care, but how they are enforced is also from different bodies. So I do know that there are areas of concern as it relates to regulation of some of the private facilities.
Thank you.
All right, so a few more questions online. Please expound on caffeine abuse. 1 cup or 1 mug, does it make a difference?
So I think you have to be guided by the criteria. Everybody has a different sensitivity. So for some persons, 1 strong cup is enough to give them, jitters and anxiety and so forth. So we're looking at the criteria that says, do you crave this substance? Do you need increasing amounts of this substance? When you don't get caffeine, do you have a withdrawal headache? Do you have tremors? Do you need to get your caffeine? When you are using it or don't get to use it, are you irritable? Do you find that I'm not going to go to work, I'm not going to do anything until I get my cup of coffee? Then yes, you would be falling in line for a caffeine use disorder. Of course, we do have to note that the different substances, of course, have different impacts in your life. But the DSM does list caffeine use disorder as being present.
All right, just a few more. Are there any Narcotics Anonymous groups for adolescents?
I can't speak to if it is specific for adolescents. There is Narcotics Anonymous, and they do meet regularly. I don't want to misspeak in terms of the age cutoff that they have for those meetings.
All right. What rehabilitation is available for these excessive users and they expose who are not users but reside in premises with users?
Okay, so that's important. I think, it speaks to the need to support our family. It speaks to the need to be able to gently come to someone and highlight concern. But if the question is what is available, so going back to the listing of what is available, so we know National Council on Drug Abuse, you are able to walk right in to be seen for any substance use issues. You can go to your mental health clinics to get that kind of assistance. And then outside of that, we have our prevention programs. So we are trying to go into schools, go into institutions where we are able to educate the public as best as possible and give them guidance on how to assist their loved ones. So to answer the question, the National Council on Drug Abuse is there as well as the other listed facilities.
All right. Why do you think cannabis is more prevalent in some parishes as compared to others, and the same for alcohol?
Certainly, so we have to look at cultural influences, the location of things. If the rum factory is in one parish, then that's going to influence the use. If there are a lot of bars in one particular parish, that's going to influence the use. So cultural, if you have a particular religious belief, and therefore there is a high population of those individuals in a particular parish, you're going to find that they are going to use more cannabis for their religious practices. So it really depends. And then there's also urbanization and the closeness of where persons live. So you're going to find in Kingston and St. Andrew, we are densely populated, and so you're going to see higher rates of substance use. So it's definitely factors that are related to the population itself and social circumstances.
All right. Okay. Can we utilize policy banning public smoking and encouraging use of alternative forms such as ingestions, gums, topical use, etc., guide those who are interested in maintaining their blood levels of marijuana nicotine?
Repeat that for me, please.
Can we utilize policy banning public smoking and encouraging use of alternative forms such as ingestion, gums, topical use, etc., guide those who are interested in maintaining their blood levels of marijuana nicotine?
Okay. So I'll answer first by saying the public health response is going to address health concerns. So there is a tobacco bill, and we are well, I don't want the ministry, right, works towards addressing and adjusting it to meet the public health needs accordingly. In terms of going down the route of encouraging them to utilize in another way, the bill wouldn't really speak to that. That would be a part of public education and prevention, and in terms of harm reduction and just education about the use. So a bill itself would not speak to guiding persons towards using in a particular way. It would be for the protection of the public, which we do have, and that is under the ministry's purview. I don't know if Mrs. Smith wants to add anything.
All right, last one. Are there any regulations for companies like Jacana and cannabis clinics recommended THC and CBDs to persons for medical reasons?
That's a heavy question.
And I won't take it either. What I would say is medical use should be monitored by a medical professional. And so Jacana or any other area outside of the medical profession should not be setting the parameters for medical use.
All right, thank you very much.
Thank you. So if there are no other questions, I thank you very much for your attention and interaction for this presentation. Enjoy your day.
All right, louder round of applause for Dr. Kristen Robinson, please. Thank you very much. That has been some significant work that she has done, and we are very proud of her. Thank you.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I could go to work and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated. Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Good morning, ladies and gentlemen. I am Mrs. Christine Ehikamenor, Genomic Sequencing Consultant at the National Laboratory Services, Ministry of Health and Wellness. In this session, we will be exploring pertinent data on the management of HIV in Jamaica. I am pleased to introduce our guest speaker, Dr. Camilla Bryan. Dr. Bryan is a public health specialist with almost a decade of experience in health program development, policy implementation, and research in Jamaica. Over the years, she has contributed to national initiatives across HIV, STI, and chronic diseases programs, supporting improvements in service delivery, population health outcomes, and the mentoring of healthcare workers. Dr. Bryan holds a Master of Public Health. She is deeply committed to education and capacity building in the public health system. Please help me to welcome Dr. Bryan.
Morning, everyone. Thank you for having me here today. So today I will be presenting on the prevalence of HIV drug resistance and its determinants among unsuppressed patients living with HIV in Jamaica. And this was a retrospective cross-sectional study of unsuppressed persons living with HIV in Jamaica between the period of 2018 to 2025. So this will be the outline for my presentation. So just to give a little background, so HIV affects the immune system, particularly our CD4 cells, and antiretroviral therapy, or HAART, it suppresses viral replication and reduces illness and death. Globally, ART access has expanded substantially, over 31 million persons on ART in 2024. So we look at our national treatment cascade. So in terms of looking at the pertinent pillars, we know that in keeping with the 95-95-95 UNAIDS targets, we know that our first pillar will be diagnosing persons, which should be ensuring that 95% are diagnosed by 2030, which we have attained that first pillar of the cascade. The other 90 would be getting persons on ART, and then the final is viral suppression. Viral suppression, which is the pillar that is circled, that is a very important pillar, because that's one of the things that are important when we talk about things such as in HIV drug resistance, if persons are not adherent with their ART. So HIV drug resistance, it occurs when genetic changes in the HIV reduce the effectiveness of antiretroviral drugs. Resistance then emerges through poor adherence, treatment interruptions, prior ART exposure, or viral mutations. So there are two types of HIV drug resistance. So primary, which it can be transmitted, so may develop resistance detected in ARV drug naive patients who would have no history of ARV drug exposure. Or it may be acquired, where persons may develop an HIV mutation post starting ART medication. And all current antiretroviral drugs, including newer classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant strains. So antiretroviral therapy groups. So there are different groups. So we have our PIs, or protease inhibitors, or NRTIs, or NNRTIs, and our INSTI. So our INSTI group, these would have been some of the latest ones that would have been added, so things such as dolutegravir, lebrikapavir, and cabotegravir, which are more used for PrEP. So in terms of our local setting, in terms of what we consider in Jamaica setting for what is our first choice for starting a patient who's an adolescent or an adult on ART, our first choice would be from option A, which would be our tenofovir lamivudine, and from option B, which we have dolutegravir. And then we have a second choice, just in the event for persons who, for some reason, may not be considered eligible to start the first choice. Then we have tenofovir lamivudine with efavirenz. So what in terms of the global HIV drug resistance, looking at it globally and in terms of the local context? So HIV drug resistance is a growing challenge worldwide. 10 to 20% of persons starting ART have resistance to at least one drug class. In NRTIs, resistance is the most common in local and middle-income countries. Among ART patients with detectable viral load, acquired resistance ranges from 3 to 8%, which can go as far as, depending on which part of the world, up to 20% in highly treatment-experienced cohorts. In terms of our Jamaican context, we would have seen that we have 28,000 persons living with HIV. There's been limited data. The last study that was conducted for HIV drug resistance by Barrows et al. Was done in 2013, which is roughly over a decade ago, which would have shown that our prevalence at the time was 12.6 as a country. And public health relevance, HIV-DR, we know, compromises ART effectiveness and then threatens the population treatment outcomes. So the aim of the study was to determine the prevalence of HIV drug resistance and then to identify the factors associated with HIV drug resistance among unsuppressed persons living in Jamaica. Our objective was to describe the types of the HIV resistance profile among the unsuppressed PLHIVs, as well as to assess the association between the HIV-DR mutations and the clinical factors. And the factors that we looked at were CD4 viral load and their duration on ART. So for our methodology, the samples, so initially we started with 212 samples that we collected during the period of 2018 to 2025. Prior to that, we were doing testing, but then there was a pause, and then we resumed testing last year, 2025. So from the sample that we had, the 212, samples were removed or excluded for different reasons. Some of the persons were either dead, lost a follow-up, meaning that they had stopped coming to care. They became virally suppressed, meaning that they no longer was unsuppressed. And some of them were not able to be found on the TSIS database, which was a national database that is used to track persons living with HIV in Jamaica. So our sample size dwindled down to 75 persons. But then we had a further 8 due to laboratory rejection, due to integrity of the sample. They were excluded, which then brought the sample size down to 67 persons. So laboratory data analysis of the HIV resistance interpretation was performed using sequencing view and SmartVer software, which this applies a quality threshold and mutation detection algorithm to identify the resistance associated variants. And in terms of our statistical analysis, this was used using SPSS version 20, which we looked at the frequencies, proportion of our categorical variables and medians and means of continuous. And we used the Pearson's test to assess association between continuous variables, while chi-square tests examine the association between our categorical variables. So for our results, so in terms of our participants' characteristics, our median age was 35. The sex distribution, 48% were male and 52% were female. 56% had a WHO stage 3 or 4 at ART initiation. And if you look on the right side of the chart, you can also see breakdown in terms of frequencies and percentage. And then median ART was 9 years duration on being on antiretroviral therapy. So in terms of prevalence that we notice in terms of HIV-DR mutations, according to the class, we realized that 100% all participants had at least one HIV drug-resistant mutation, at least one. 99% were resistant to the NNRTI groups, which would have mentioned before. This would include agents such as efavirenz, which are agents that we use in our treatment algorithm, and the 76% to NRTIs. PIs were 28%, and our INSTI, which is dolutegravir neuro agents, was 12%. In terms of the pattern of resistance that we noticed across the class, the majority of the participants demonstrated resistance to multiple drug classes. So we had 43% having resistance to 2 drug classes, 31% resistant to 3, 22% resistance to a single class, and then we had a small minority of 3% that exhibited resistance to all 4 classes of drugs. So when we looked at the factors associated with HIV drug resistance, there was no significant association that was found between the number of HIV DR mutations and their viral load, nor was there any association found between their HIV DR mutations and the time on ART. A significant inverse correlation was observed, however, for lower CD4 counts at ART initiation and the number of mutations that were seen. So basically, the lower CD4 would have shown that these were late presenters, or they would have had delayed initiation on treatment. So, that persons who, this would then result in them having a higher risk of a resistant mutation. So some of the discussions / implications. The findings from the study indicated that there was a high prevalence of drug resistance mutations, particularly amongst the NNRTI groups within this population that we looked at. The resistance, although less frequent, there was integrase resistance, which was identified at 12% of the participants, which may raise some concerns given that this is this is a central role in terms of our first-line therapy, and also it is also used in what we use for our third-line therapy as well. Resistance, their lower CD4 counts at ART initiation were associated with higher numbers of HIV DR mutations, underscoring the risk of late diagnosis and delayed treatment initiation. Some of the limitations for this study, we had a small sample size. The analysis was just confined to the 67 persons, which may have reduced our statistical power and limited the generalizability for us using it and applying it for the broader population of PLHIVs in Jamaica. It was a retrospective cross-sectional design. Resistance was assessed at that single time point, preventing evaluation of temporal changes or causal relationships. There could have been selection bias because a large population of initial samples were excluded due to different factors that I had mentioned, either mortality, viral suppression, incomplete records, or integrity issues that could not be analyzed. So that could have introduced bias. Or there's also data availability and feasibility constraints, looking at further key variables. So with this, some of the recommendations would be, looking at HIV drug resistance testing for our unsuppressed population, strengthening the monitoring, in particular for NNRTIs and our NRTIs resistance, because these are pertinent in terms of our backbone in our first-line therapy, and implementing targeted surveillance for our integrase resistance. Yes, it is 12% of our unsuppressed population, but something that is, it is important to monitor in terms of, doing other studies to monitor. Promoting early HIV diagnosis and timely initiation, which is something that is done once persons are diagnosed, they are started on ART in a timely fashion to ensure that they are on medication, because to reduce the risk of the outcomes that are associated, and also to reduce the risk of HIV DR. and reviewing a long-term ART management for unsuppressed individuals. Because one of the things that are that can cause HIV-DR is suboptimal adherence to medications. So just to ensure that persons are being adherent with their medication, that can also reduce the risk of HIV-DR. And a follow-up study with a larger population size is recommended, just to incorporate in some of the key variables that we did not look at in the first initial study, in this study, to allow a more comprehensive assessment of the factors assessing and influencing HIV-DR for the country. These are my references and acknowledgements, and I thank you.
Thank you, Dr. Bryan. We'll now go to our question and answer section. So if there is any question for Dr. Bryan or any comment.
Okay, yes, a few online. What were the selection criteria for patients studied?
So the selection criteria for the patients that we looked at were in keeping with persons who would have fit the criteria for HIV drug resistance, which would be persons who would have been on first-line therapy for 6 months consecutive without achieving viral load, and then also persons who are on second-line therapy who would not have, based even with adequate adherence, they still would not achieve viral suppression.
All right, next question. Are all mutations regarded equally?
No. So not all mutations are regarded equal. So depending on the type of mutation, they may be more specific for certain classes or certain drugs, certain drug groups. So it depends on the type of mutation that you will see when it is analyzed, and then that depends on which class it is associated with.
All right. Given that individuals on ART are often outliving those with some non-communicable diseases and successfully building families with HIV-negative children and partners, how can those stories be levered in public health campaigns to reduce stigma here in Jamaica, where cultural attitudes may still lag behind medical advances?
Okay, good question. All right. So, I mean, it's a lot has to do with public education, which I know the HSTU has been one of their mandates to inform persons, ensuring that persons are educated in terms of knowing more about HIV, especially particularly the stigma where that is associated, and also in trying to to see how is it that not just having HIV, but I know also the NCD unit, they're also doing a lot of health promotion, whereas we try to ensure that the messaging are getting out there so that, yes, you may be living with HIV, but it is just a comorbidity, just like your other comorbidities, pressure, sugar, asthma. So you can live long and healthy lives. It's just to get the education out there and ensuring that with the nutrition on board, which I know the nutrition unit and the physical activities with the HPNE has been, they've been all working collectively to get information out there that this is something that persons can live long time with.
All right, thank you. All right, another question. Have you compared these genotypic findings with phenotypic resistance data for the same samples? Were the samples representative of the patient population, including different subtypes common in Jamaica?
All right, so let me put that in two. So I think we look mostly on genotypic. Based on the type of test that was done, it was mostly genotypic testing to see what type of genes were present, so we could then associate it with the group that's of ART that you would have the resistance with. Not phenotypic. Most of the tests done are mostly genotypic tests that are done, and also in terms of, what was the second part? Sorry.
Second part,
I was trying to just
were the samples representative of the patient population, including different subtype common to Jamaica?
No. So that's one of the recommendation to conduct the study using the general population group, because this was more selective to that group of persons who were just unsuppressed, meaning that their viral load were not undetectable or under 1,000. They had high levels of viremia. So these were that selective group of persons that we looked at to see in terms of what types of resistance may be possible in this cohort particular.
All right, thank you. All right, next question. Is there an opportunity to have ongoing routine HIV drug resistance surveillance?
And
example, would local lab capacity need to be strengthened?
Yes. So I will answer the first part, and then I will hand over to Christine and PHL aspect. So yes, because HIV-DR, it is a serious problem globally. We're not the only country that's having that challenge. And as I said before, globally it's within 3 to 8% for persons who are on ART. Some studies I've looked at, you can see, even for our newer agents like our DTG, up to 19% resistance, which is a problem because it forms the backbone in our first-line therapy as a country, and it is also incorporated in our third line, what we call salvage, which that's it. So it is very much important as a country that we look at in terms of monitoring and surveillance for HIV-DR in the country. And in terms of lab capacity?
So just to say that HIV-DR sequencing started prior to 2018, but in 2020 when COVID hit, the facility had to give over to COVID testing. So we had to stop sequencing testing. So we started actually formally in September 2024. Currently, our director, Dr. Marlene Tapper, and the HR arm of the Ministry of Health is looking at building capacity so that we can fully look at how to do the sequencing for PLHIV in Jamaica.
All right, thank you. Just a few more questions. How can we improve patient management to improve medication use, compliance, since the lack of adherence to medication protocols is a major cause of mutations which result in drug resistance?
All right, good question. So it's a multifaceted approach. So yes, we have our clinicians. Yes, we have our different arms of treatment. We have our social workers, we have our adherence counselors that are involved in the program that also look at, and our psychologists and psychiatrists that looks at the different factors that contributes to persons not being adherent. And they work with the team, but then it's a wider in terms of perspective, looking at in terms of community-wise. I mean, I know that HSTU, they do a lot of training in terms of with the clinicians to ensure that, persons are, are aware of what the guidelines are. The guidelines are updated to ensure that, and disseminated so that persons are aware of what the current regimen options and choices are. And then also, there are a lot of work that is done by civil societies in terms of health promotion, getting the information out there, as well as trainings, as well as in terms of stigma and discrimination. So it's a lot of different moving parts that are happening at one time to ensure that that is happening.
Okay, last two. Is there a home testing kit? If yes, how do you capture the persons who get a positive result on those?
So yes, there is. HIV, in terms of for HIV testing or HIV DR? Or regular HIV testing? Because I'm answering to testing.
Both.
So for HIV testing, yes, we do have HIV self-test kits in country. And you can get them at different locations. I know through civil societies or pharmacies. They're distributed through that, and you can do them. The instructions are there. And as I said, I know lots of information and education has been done in last year and before when they just was introduced to, so that persons can know that they're aware, and it's an option. For the HIV DR, no, because it's, technical, yeah, it's a lot, yeah. So, and it's a lot of algorithm based, and then you still need to then have it through the whole sequencing, and then analyzing and then interpreting based on the type of resistance that is identified to match it back to the class. So it's a little bit more technical. Okay, much more technical.
All right, last one. When the prior national HIV-DR study was done in 2013, dilute Gravir was not yet available.
No.
Do you believe accessibility of such drugs on the market to have a significant impact if another wider study is done?
So dolutegravir was first FDA approved in 2013. And then globally accepted as first-line therapy by WHO in late 2018, 2019, which we have integrated it in our first-line regimen for all persons who are PLHIV. And then the FDA took it a bit further because of its awesome properties to now have a children formulation, which the country of Jamaica adopted in 2024. So it's a second generation, in terms of pharmacological profile, it's a second generation integrase inhibitor. So in terms of the barrier for resistance, it's a lot less compared to the first generation, such as, or its older cousin, I would say, raltegravir. So you have a better barrier in terms of resistance. But yes, we know that it is available, and it's, out of the studies globally, persons are testing because it's new, as I said, it's fairly new. So out of the studies, you'll see different variants in terms of resistance. It depends on where you look and which part of the globe. So you'll see between 3 to 8, but you can see as far as up to 19% for persons who are heavy, who've been long exposed, like heavily exposed to different regimens. So, it really, in terms of all of the side effects from the older agent, there's not that much side effects in terms of, it's a more better side effect profile, if you look at it that way. But we also, it's something that is new, but we still have to monitor it, so we know exactly, just like what is happening globally, so we know exactly what is happening for our population, and then how is it that it can, we can adjust our program so that we are, ensuring, we want is patient outcomes, improve patient outcomes.
All right, thank you. That's it for the online questions.
Thank you. Thank you.
Okay, so we thank you very much, Dr. Brand, for such an awesome presentation, for the knowledge shared. If there are no other questions, we'll now go to our commercial break.
At age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my home. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis, to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated. Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated. Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated. Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children.
Make sure that I can see and everything.
Good morning, everyone. Welcome to feature presentation number 4. I am Dr. Andreen Grant, the chair of the National Health Research Conference Secretariat and Director of Epidemiology Research and Analysis within the Ministry of Health and Wellness. Our guest speaker for this session is Professor Trotman Edwards. And our presentation is entitled Ethical Concerns on the Integration of Artificial Intelligence in Health Research. As we think about artificial intelligence, we recognize that as we progress in the 21st century, we have seen great advances in science and technology, including the rise of AI, or artificial intelligence. According to Fei-Fei Li, who is considered one of the architects of AI, artificial intelligence is the future, and the future is here. And so we turn our next session to this topic, and this is going to be led by Professor Helen Trotman Edwards. Prof. Trotman Edwards is a professor in the Department of Child and Adolescent Health at the University of the West Indies, Faculty of Medical Science, Mona, Jamaica. She serves as a consultant neonatologist with a research focus on pediatrics and neonatology. Prof. Trotman Edwards is currently the chair of the Mona Campus Research Ethics Committee and holds a master's degree in bioethics, a master of public health, and diploma in child health. Prof. Trotman Edwards completed her Bachelor of Medicine, Bachelor of Surgery, and her Doctorate of Medicine in Pediatrics at the University of the West Indies, Mona. We now invite her to come forward for the next presentation. Let us give her a round of applause.
Okay. Good morning, colleagues, ladies and gentlemen. I'd first like to thank the organizers for inviting me to present on this topic, which is ethical concerns on the integration of AI into health research. Now, the outline for this presentation, we'll look at some ethical principles that exist. We'll look at the promise of AI in health research, current applications of AI in health research, what are the ethical concerns. We will go through the WHO core principles for responsible use and development of AI, and then look at some strategic recommendations for Jamaica. Now, why research oversight? Right? History teaches us that researchers cannot be left to self-regulate. In the past, we have had some egregious breaches. Health research downstream, and that's what we are here about, can translate and should really translate to clinical care and patient outcome. Therefore, bad science can result in harm. Now, the question is not, is AI or should AI be used in medical research? I think that question is out, that horse is out the gate already. I think what the question is, the existing guardrails that we have now, are they in and of themselves sufficiently stringent, robust, and agile? And why I say agile is because as I'm speaking here today, probably what I have on my slide is obsolete. AI, what I have read and put there is obsolete because AI has gone on. So is it agile enough to govern AI integration in medical research? Okay, so what are the current guardrails we have? And they have stood the test of time. What we are looking at, can they go into the future? So we know that there are three basic ethical principles. Respect for persons. So we know that persons must be treated as autonomous agents and as far as they can, self-determine what happens to them. On the other side, people who have diminished autonomy, for instance, your children, prisoners, they need to be protected. So the practical application of that respect for persons is informed consent. And remember, informed consent speaks to information given, the information is understood, and then the person voluntarily agrees to participate. And those three things are very important. That the information is given sufficient information, there is understanding, and therefore the decision is voluntary. Beneficence embodies minimizing risk, maximizing benefits. So we want to prevent harm. And justice is that we don't want disparities, and we don't want one set of people bearing the burden and another getting the benefits. So we talk about fair selection of our study participants. So that is research, but then we have principles for the conduct of researchers. And I think people forget that, right? We depend on researchers' integrity, honesty, and accountability. And with AI, these things are very important as we come on to them. So no fabrication. People are not supposed to be making up results, just making up results. No falsification. So, okay, you have a hypothesis, you have done your study, these are the results, right? Your hypothesis is wrong. We don't expect you to, well, you know what? I'm going to suppress some of this data, tweak it here, tweak it there, and then come up with, yes, my hypothesis is right. So no falsification, no plagiarism, right? We respect intellectual property, and we assign, ownership where it belongs. Fair authorship. And this is something that maybe we don't look at as much as we should. You should be integrally involved in the research to be an author. It shouldn't be that because I am the senior person in the department and this is going on, my name gets tagged on. Fair authorship. Declaration of conflicts of interest. Very important. We are not saying that you may have a conflict of interest. It doesn't mean that that's going to affect your research. But I'm coming up here and I'm saying to you, I belong to so-and-so, so there's this conflict of interest. This is the way I have dealt with it. So we have ethical principles for the conduct of researchers. We have ethical requirements for data protection of confidentiality and privacy. And that comes under your respect for persons. If you respect people, then if you ask me questions and I give those answers, I expect you to treat them in a confidential manner, right? Privacy. So we have things that govern how do we collect data, right? We do it in privacy where other people are not hearing, etc. Data storage. Who gets access to that data? Right? What can they do with it? Data maintenance. How long are you going to keep that data? Right? How are you going to maintain it? Is it going to be locked away where no one can get to it? If it's on your laptop, are you going to have a password? Are you going to encrypt it? How are you going to maintain that data? How long are you retaining it for? If you are going to share the data, and this is going to come very important with AI. If you are going to share the data, then the persons from whom you got the data need to know who are you sharing it with, how is it being shared, how is it going to be used, how long this third party is going to have access to it, right? What is going to happen to it? When is it going to be destroyed? So we have things that govern that, right? And there are data protection regulations. In the USA, you have HIPAA. In the European Union, you have the GDPR, and we know from that's a mistake. It's 2020. There's no such date as that. 2020, we have the Data Protection Act for Jamaica. But in these three regulations, there isn't a specific. So while we speak to data protection on a whole, we have not drilled down data protection with AI. And that is something we have to look at. Okay, so what is the promise? Because everyone is excited about AI. And I must admit here that I'm sort of late to the table. I am one of those who have been, well, let me wait and see. I don't know where this is going. I'm admitting, right? And in fact, this talk has opened up because I've had to do research, right? But what is the promise? And there's some good promise here. Drug discovery, right? AI can accelerate the analysis of molecular data sets, reducing development timelines from years to months. So drugs before that would take 10 years or so. There's a possibility that we can get them to market faster. Now, in saying so, getting them to market faster, we still have to have guardrails, because when they reach market, you don't want to now be finding these unwanted effects. So it's a balance. But the truth of the matter, accelerate. Medical imaging, I think this is a big area. I read a lot of papers where they have been looking, studies. They look at radiologists and versus AI in analyzing films, MRIs, etc. And they are showing where AI can be just as good or even better, picking up things, right? So it enables earlier disease detection with diagnostic accuracy that can, I'm not saying it does, can exceed human radiologists. I think genomic analysis is an area that, has a lot of hope, I would say. So processing the whole genome sequences to identify mutations and predict treatment responses. And coming on from that is your personalized medicine, where my treatment is tailored to my body. So both of us may have the same disease process, but what she's going to get and what I'm going to get is going to be different because it's tailored based on how I would respond. And I think that this is an area that, really has a lot of potential. Decision support. So it can assist providers in diagnosis, treatment, planning, patient monitoring. And I have been very intentional on the words I am using. I'm using things like assist. I'm using things like help, things like optimize. And I'm using it because I want to say it does not replace the human oversight. If you take nothing away from today, AI cannot replace human oversight. Systems management, I think this is a big area where it reduces administrative burden and improves your resource allocation efficiency. That's a big area. And disease surveillance, right? It enables real-time epidemiological monitoring and rapid outbreak response. So these are some areas, the promise. Okay, I want to bring it down to us now. Individual researchers. So it's got those big promises. What does this mean for all of us in here who are doing research? Individual researchers. And let me start off by saying that I'm expressing some of these things I'm expressing, and when I do it, I'll say, this is my opinion. Okay. Research brainstorming. What does that mean? So I go back, and I may be dating myself here. I go back to when I started, right? And I'm sure a lot of the young people in here don't know what index medicus is. Never heard of it, never used it. So let me just give you all some history. So you want to do research, right? This is preceding about 2004. You want to do research. You go into the library, right? And there's this index medicus. So I am saying, okay, I want to look at infant feeding and body composition. So I go in, and they'll have infant feeding. I pull it out, and they have all these index cards, right, with research and the journal. I write it down, guys, not type it into my phone. Write it down on my piece of paper, right? And then I look in the library. I don't want to say 90% of those journals are not in the library. I then go to the librarian who have to send off, right? That may be 2, 3, 4 weeks. Then when they find it, you have to pay because it has to be photocopied. It comes back and you end up with a stack of papers like this. Then you sit down, okay, the first journal article I go through, and then I go to the references. And I go through and say, okay, this, and give another set. And so we're going. So my literature review, 6 months, 9 months, coming out from under the stack of papers. This is where I see AI can be helpful, but you have to use it responsibly and ethically. Right? Because coming from Index Medicus, we went to PubMed. Oh my gosh, when PubMed came in, that was like jumping for joy. Right? You put it in, and then you get 5,000 citations. And then after you say, nah, man, I can't go through 5,000 citations. So, I change it, and you tweak it, and it comes down now to about 300. Then now I have to go now and read those abstracts and say, no, this is not that. So what I'm saying here, where I see AI can help, is in that process. Because what will have taken me 9 months, what will have taken me 6 months, whatever, AI can pull relevant papers. But there's a caveat. You still have to do the work because AI hallucinates. Somebody called me the other day. Oh, they are looking for this paper I wrote on NEC and they can't find it anywhere. Can I send them a copy? I said, what? What paper is this? And they have other people I work with, cited. That's called hallucination, guys. So you cannot depend on AI to do your literature review. What I'm saying, it can help you pull the papers, and then you go back to what I do. But the thing is, it can cut off 6 months. You get to a point faster, but you still have to have those 300. You still have to look, because you can ask AI to summarize it for you, But they can summarize some things that don't belong there. So the work of a literature review still belongs with you, the researcher, right? You can use it to brainstorm because you say, okay, in that area, where I see that it can be good is that you may have a thought in your mind and you want to bring something unique to the literature. You don't want to just repeat what's there. AI has the ability to look in there and say, this area has not been really looked at in your situation. So it can give you, so that's why I say brainstorming, enhancing your creative hypotheses, streamlining collaborative innovation. So there's a place for it there, but I am stating categorically that literature review belongs to you. Writing the literature review belongs to you, not AI. It will get you in trouble. You'll have a beautiful literature review and 3, 4, 5 of the articles cannot be found. So, yes, research brainstorming. We have spoken about the literature review. It really does, I see a use for that because it cuts out what I call the administrative, repetitive, mundane parts. But the creative, the analysis belongs to you. All right, efficient data processing. Another place that I can see it, and particularly, so I'm not talking, and let me put a caveat here. If a student is in a program and they are learning research methods, I am not advocating that the student is using AI. I think the student needs to go through those steps, right, to know how you do research methods. Right? So I'm not advocating that students just jump on and do that. We still have to learn. But one of the areas I can see, particularly if we are doing national surveys, think about a national survey where you have so much data, data cleaning. I can see AI. Now, let me tell you something, and again, if nothing else, you take away. Do not upload your data set into AI. Let me do it again. Do not upload your data set into AI because you don't know where it's going, you don't know who using it, you don't know which model using it, and you don't know what it's going to say about your data. Now, I'm not a techie person, but I've checked with the tech, and what they say you're supposed to do, you can have AI interacting with a software program on your device. So the AI, say I'm just using Excel, the AI may say, okay, run a frequency on whatever. Excel runs it, and all AI is getting is the output. They are not getting your data set. Do not upload your data set. Cleaning I can see, because AI, you can give AI the parameters. So say I'm looking at, and I'm sorry if I'm only using examples from my area, but I'm looking at babies, I'm looking at mothers. I know there's a range for the birth weight, right? So I can give AI that, if birth weight between X and Y. I know mothers in terms of pregnancy, although we're pushing those borders, but usually I would put in something 14 years to 45, right? I'm not saying the outliers may not be true, but you need to go and look at those outliers and make sure. So you can give AI the parameters. AI interacts with your software, runs that frequency, and flags all the things that come outside of your parameter. Remember, that is what I would do manually, I would run off, when I clean my data, first of all, it should be double entry, so you have 2 data sets, right? And then you're looking at the output, and you're looking to see, right? And even if you didn't do double entry, you run all those frequencies, and then I'm going to run down manually looking for any age above this, whatever, and flagging it. Of course, that's going to take me a long time. AI can do that like that. I have put the parameters, and it flags it, and then now, AI is not going into your data set to fix it, You then look at what is flagged, find it in your data set, go back to your questionnaire, has a mistake been made, and you can fix it. So data cleaning, I can see, can be done. Data cleaning takes a long time, and if you do double entry, that's even a longer time. AI can do that for you in no time. You go back, find those. The other beauty I love about it, if you are doing a prospective longitudinal study, you can actually have that AI interacting with your program at the end of every day and picking up the mistakes at the end of every day. So say we're doing a national survey. You can pick up certain things. If you see in a particular parish, but wait, there are a lot of errors, maybe that's suggesting to you need to go back and do some more training with your data collection team, right? Or you can correct. So it is doing it in real time. So you're doing this prospective study, a survey, a national survey. At the end of the year, it's running from January 1 to December 31st. At December 31st or January 1st of the following year, you have a clean data set. You have a clean data set ready to go, something we didn't used to have before. So I can see its use there. And again, guys, we did not put the national data into AI. AI interacted with a program on my computer, on the ministry computer, and all they got was the output. Very important. So you can get these clean data sets, you can get them quickly. So what it is, it's an optimizer. It's a tool. It doesn't replace what you're doing as a researcher. It's optimizing. You are getting to those points quicker. Let us speak about data analysis. Again, we're not uploading our data set. It does not replace a statistician. Let me be clear. It does not replace a statistician. That interaction with the statistician should have happened at the beginning when you were developing, and they would have given you guidance. What it can do, though, is you are now there. You can say, it can, again, interact with your SPSS. So let me go back to when I'm doing my basic statistical analysis with SPSS. Sometimes you want to do something and you're not quite sure how to do it. So I will go on Google, how do you do so-and-so on SPSS? A set of YouTube videos will come up. I will sit down, I'll watch it. I say, oh, okay, and then I go and do it. Everyone has done that. Come on, tell me. Oh, come on. Y'all don't play like y'all are. Okay, so everyone has done that. So again, this is where AI can come in. Because you can say to it, in your language, natural language. See down there, say natural language querying. So I'm not saying it in a big statistical way. I can say it in my plain layman's term. I want to see if maternal so-and-so causes so-and-so with so-and-so, da-da-da-da. And it can say to you, it can say, well, this is what you may have to do. And if I don't know to do it, it can interact with my SPSS. It can be set up such a way, it can interact, and it does the syntax. It does the syntax for you. But all the AI is getting is the output. So the AI is not getting your data set. They are not seeing what's in your data set. They are seeing the output. Now, so what we are saying is it can help you. But let me state here, analysis, the interpretation, what does this mean, belongs to you. AI cannot be a co-author. Right? AI cannot be a co-author. And when they're retracting the paper, they don't retract it from AI. It's your name. The analysis belongs to you. So yes, it can help you check. And suppose you did it and you're not quite sure. You can say to AI, okay, can you run so-and-so and see what the output is? Is it the same output that you have? And you know, yes, I've done it correctly, or no, I have not done it correctly. So again, there's a place for that. And I keep on saying, I see this in when you're doing big data sets. Students, you know, and that sort of thing, I don't see this, but I'm seeing this, you're doing something across the parish, you're doing it across big data sets, right? But even in your little data set, you can use it, but you use it responsibly. So data integrity can help with, because if you have reliable, validated data sets, right, then we know you now can move on with trusted data, because that's one of the things. Is my data clean? Because as I tell people, rubbish in, rubbish out, right? I tell my students, you know, I say, if you don't clean this, because when I tell them how cleaning go, you know, they moan, they groan. Oh, I have cleaned my data set. And then the first frequency I run, I say, so what this is? What this is? Oh. I'm telling you, it's truth. They say, I've cleaned my data. I say, it clean. The first frequency I run. I say, so why is this woman who had a baby 80 years old? Oh, I missed that. That means you didn't clean your data set. And we're not moving forward. Because when I sit down and go through statistical analysis with you, you're making me do rubbish. Rubbish in, rubbish out. So in terms of data integrity, it has a place, right? And high quality data improves how you reproduce it. So when I send my data, you know if X, Y, and Z run this, we are all getting the same thing. Again, research quality, right? In terms of looking at what you're doing. So again, this is not saying to AI, I want to do so-and-so, write a methodology for me. Absolutely not. That's not what this is saying. What this is saying, I have a research question, I have thought about it, I have come up with aim and objectives, I've done my literature review, I know this is my methodology, this is what I plan to do. There's room for saying, okay, if to AI, this is my hypothesis, and this is what I am doing. I'm not putting out my proposal, you know. I'm not giving AI my proposal. I am giving, I'm not giving the proposal. What I'm saying is, I may say, this is my hypothesis. This is my aim. I can give it to my aim. Right? These are my objectives and my hypothesis. Right? What may be the best? And I plan to do X, Y, and Z, da-da-da-da. Is this, you know, the correct or the most efficient or whatever? And it may be able to say to you, well, you haven't considered, and it can do that. You haven't considered these, say, extraneous things or whatever. How are you going to do? And it can help you streamline your methodology. it is not doing your methodology for you people, right? It can help you. And also with those suggestions, you know, you can maintain professional standards. So I can see where we can have these clean data sets that can be reproduced, right? Where the methodology is sound. Sometimes we see coming to ethics, someone has aims, objectives, hypotheses, and they have a methodology. And you look at the methodology and say, but wait, it can't. How are they going to achieve these objectives using this methodology? Exactly. And then when we send back and say that, we get cussed, you know, because we want to change people research. That's what we get. When we say, well, you know, I'm not changing your research, you know. But if you do research, if you set about with a methodology that cannot achieve your aim, then your results are useless. And you're wasting people's time with all doing questionnaire, whatever, where you cannot get results that are useful. So I am not changing your methodology, you know, but you better find one that could achieve your aim, because it's unethical to conduct a study for which you cannot get correct and robust results. So again, this is where the robustness, I can see the improving, because it can say to you, you have not thought about these confounders. Or based on this, you will not be able to achieve this. So that sort of editing, that sort of help is coming before it even reaches to the ethics committee. So I can see where. But as I said, you're not asking it to do your methodology. You're not putting your proposal up there, right? You are asking questions. And the AI is interacting with software on your device. So the AI not seeing your results. All right. So even with grant proposals, right? It's useful because, again, streamlining. I would not put up my whole grant proposal into AI. I'm just saying, that's me. Other people can do it, I'm not. I may take a little part, you know, and say, how can I, these are the funders. You can put up what the funders want. That's in the public domain. So this is what the funders want, and I want to be able to fit what I'm doing. Because, you know, sometimes you have to fit what you're doing into what the funders want. Because if you don't, you're not getting funding. So I can see where it can help you streamline, align it, right? Align certain parts. Budget. That's something you can, you know, budget. You can say in Jamaica, this is this. How does this translate? Help me with the budget. But again, I'm not putting up my grant proposal. This is just me. Other people may do differently. Proposal submissions. We spoke about this already. Coming to the ethics committee, right? Again, in terms of improving, editing, whatever. Now, in saying that, what is coming out more and more, and I think it's going to be standard in the next few, I don't even want to say years, probably months, you are going to have to, when you are going for publication or whatever, even if you're and submitting, you have to say if you used AI, where you used it, how you used it. The importance of that is that you must keep versions of what you are doing. You have to be able to show, because if somebody challenges you, you have to be able to show this was version 1 that I did, right? Then I asked Grammarly to help me with my English or whatever. Post that, this is the version. So people are seeing. So data, keeping your data and your process is very important, because you're going to have to be able to say how you used it, when you used it. And people can ask you, well, show me before you did and after. So remember that now. Keep different versions. I have so many versions, sometimes you get confused. And you send off the wrong version. But you have to keep with AI. If you're going to use AI, you keep your version so you can show. You have to keep your data set, because people are going to say, let me see. The other thing, right now, we say 5 years for keeping your questionnaires. Now with AI, you know, I am thinking maybe you're going to have to put those questionnaires into some sort of soft copy to keep it, because people are going to want to say, show me that you did these questionnaires, because remember AI, AI can formulate the questionnaire, it could answer it, and it could give you a data set. So you're going to have to keep that as proof, and that is coming. So start thinking about keeping versions. If you use AI, declare. Don't declare, and then when your challenge say, well, I'd use it for this and that. You start off at the beginning. You declare, I used it too. This, and you can show. Okay, and the other thing I was going to say that AI can help you with, again, it is interacting with your device and software. So you know that for your graphs and that sort of thing, you may use Excel or whatever. AI can interact with Excel and tell Excel, produce, these graphs, produce whatever. AI can, now, the caveat here, AI can also produce images. I am not going to use AI to produce any image because you can find yourself in trouble. Be very careful, right? Because imagine somebody wants to prove a point or whatever. I can say, make a slide to show that there are lymphocytes, blah, blah, blah. And then I say, this is an example from my research. Of course. Right, of course. Right, you're not doing that. That's fabrication. But be very careful. And if you use it to generate an image, you have to say, right? And this does not represent, data from my study. This is just being used to illustrate, blah, blah, blah. And I say I'm just giving my personal, I'm not generating no image with AI. That's me. But if you're doing it, be careful. Okay, so what are the current? As I said, we can't say whether we already have current applications of AI in healthcare. Diagnostics and imaging, right? Pathology, tissue classification, genomics, sequencing, drug efficacy, prediction. This is already being used. Electronic health records, telemedicine, patient surveillance, right? Improving diagnostic accuracy, reducing errors, expanding healthcare access. It's already here, guys. So for us to say, should we be using it? It's here. What we have to say is, how do we use it responsibly and ethically? So what are some of the ethical challenges? The biggest one, bar none, is privacy and confidentiality. Going to say it again, don't upload your data set into AI. Because it goes, you don't know where it is. AI models, require numerous, millions and millions of data sets to be able to train. People who are training the AI models, they do it on data set. Right? So if you happily upload your data set, you put it in the public domain, You can't come and say, well, I didn't mean for it. You put it in the public domain. So do not upload it. Because the biggest thing is privacy and confidentiality. Right? You say you de-identified it, but they can be re-identified. And AI can do that faster than we're speaking here. So you think you have removed all, identifiers, and you put it in, and in 2 seconds, right? What is the danger of that? The danger is that you can have certain populations being stigmatized, right? Remember, AI has no moral agency, No moral agency. If you are looking at your data and you are finding something that is really off, you're going to say, no, man, let me look at this again. Can this be really true? AI don't have that. What it does, it encodes it into its algorithm, right? So you put something out there, and it say that Jamaican people don't like to bathe. When it's cold, we don't like to bathe. Right? When it's cold, we don't like to bathe. AI put that in its algorithm, So then it's working. It moved from Jamaican people don't like to bathe to, you know what? Jamaican people dirty. right? And then that is just going on and on and on. Because it has no moral agency. If I see something that is really out, I'm going to say, no, man. I know in Jamaica we bathe. So it must be I have entered something wrong or whatever. Let me go back and look, right? So we have to be careful. Cyber security threats. Remember, people can target, right? And it's data breaches. Commercial exploitation. Where is that data set going? Who is using it? And they may be able to sell it to a third party, right? Vulnerable populations are heightened risk of data misuse and surveillance, right? And as I said before, the governance structures we have lack specific AI guidance. So the biggest ethical challenge is in privacy and confidentiality. Accountability. Remember I told you about the hallucination problem, right? AI will generate a plausible sounding but factually incorrect medical advice with high confidence. High confidence. But you know, we have some people, so too, you know, it's not only AI. We have some people who do that too. But anyway, but you know, you're able to figure out the people, but you cannot figure out AI. Let me tell you why. This thing called the black box. I don't know if people understand the black box thing. So AI, you give it an input and it gives you an output. But the black box is you do not know the different pathways, the different algorithms it has taken to come to it. So let us use a practical example. A student is trying to solve a theorem in math. So they start and they have 10, 15, 16 lines of working. The mathematics professor can come and look at line 1, yes, 2, 3. Reach line 10 and say, no, a mistake has been made here. So everything after this is not correct. It's inaccurate. And so your output is inaccurate. We cannot do that with AI. We are not able to go in and follow. So we put an input, we have an output, but there's a black box. Who takes accountability for that? You have to think of it carefully. AI is not a co-author. Who takes accountability? Right? So that black box, that hallucination, it can generate things. It can say they found this paper that proved blah, blah, blah. And if you foolishly just go and put that, you're going to be in trouble. Right? You cannot distinguish AI hallucinations from evidence-based information sometimes. You just cannot. Right? And we know there's a rapid dissemination. Misinformation spreads faster than true information or corrections. You notice the corrections are never, it's in a little, you know, you have to take out a microscope to see the correction. But when the misinformation was coming around, it was big and bold, right? Patient harm. Because remember now, patients are now going to Dr. Google. They Google, they find, they come and they tell you, oh, doc, I didn't do so and so, you know, because, right? So they can treat or self-administer harmful interventions. And misinformation undermines public health campaigns. Because once it came out there, you know, it undermines. So accountability. Source of bias. Very important. We spoke about it before. But training data sets reflect historical healthcare disparities and systemic inequities. So it all depends on what that AI was trained on. Now, you know we have a lack of information about ourselves in terms of low and middle income countries, etc. So you have AI that is being trained on a data set from North America. And it's now, you're now going in there and it is translating that to Jamaica. You see what can happen? I mean, everybody who does research in Jamaica knows one of the hardest things to come up with is something to determine socioeconomic. You know that. So if you're using, okay, do they have, you know, cell phones? Do they have an iPhone? My gardener have 3 phones. I have 1. So if you're counting the number of phones, we're in a different economic bracket, right? I remember when they used to have satellite dish. You see a little wooden hut and a big dish on top of it, and you wonder how that roof not fall down. So if you're using that, and so in Jamaica, we use specific things that are unique to us. You know, when we say outside bathroom, I don't know what outside bathroom mean. We know what it means. When we'll use how much distance to a standpipe, right? So these are things that are uniquely us. But if that AI is not trained, and this is the importance, ladies and gentlemen, of us doing research about us, so that we are not using North American, we're not using European, you're not using UK, and transforming it into, because some things just don't fit. And once it gets into that algorithm, you know, it encodes it, and that bias. So marginalized groups, again, disproportionately. And remember, we spoke about justice, right? All right, informed consent and patient autonomy, another big one. When you get consent, remember we said information, understanding, voluntariness. When you consent your patients, if you're going to use AI, you need to consent them for that. We now have to say to researchers, if you are going to use AI, right, you have to consent them. Think about just regular consent for regular little things, how in-depth and sometimes difficult that is. Now think about telling them about black box, which even some of us don't even understand what black box phenomena is, right? But this is where we are going. If we are going to start using it in healthcare, even in healthcare, you know, when we are consenting them, no. If we are using AI in healthcare to help us with diagnostics, whatever, we need to consent to our patients and give them an opt-out. So consent, informed consent and patient autonomy, right? Patients cannot understand how AI systems work. We don't understand how AI systems work. Lengthy forms that will overwhelm patients, right? As I say, as I'm speaking right now, some of the things I'm telling you obsolete. So you take a consent form from me now, by next week, what, you have to reconsent me, right? There are imbalances. Patients may feel pressured, right? I want to come into the 21st century, and AI is the 21st century. They may feel pressured to use it. And again, as we said, transparency, right? Liability. Who is liable when AI makes errors? Who? Hallucinations, unreliable outputs. Remember I said, AI has no moral agency and it cannot be an author. Right? Okay, regulatory compliance issues. AI tools are deployed faster than regulatory frameworks can evaluate. And therefore you have a governance gap. Because we're sitting down in this room together as a committee, coming up with, you know, governance. And by the time we finish the meeting, something new has come out in AI, right? So AI tools must adhere to the medical laws and regulations. And as I said before, these do not have specific things for AI. Okay. So I've told you all the ethical concerns. How do we manage that? Now, you would recognize that some of the guardrails we have already, you know, it's already there. It is about strengthening them and making it more agile. I think the biggest thing is because AI, so those principles I gave you have been there from the Nuremberg, from there. That's from where we had those principles, and they have served us well. But AI is rapidly. So how do we keep up, right? So WHO has come up with the consensus principles for responsible AI development. So protect autonomy, ensure human oversight and decision-making authority. So remember I said, it's not AI doing it. AI is a tool to optimize. It does not remove human oversight. We have to ensure that AI systems benefit populations equitably. We have to prioritize safety and we must not cause harm to our patients. We must ensure transparency. So AI systems must be understandable and explainable. And black box algorithms, we have to be careful of those, right? Because it encodes biases that you will then take up and use in your medical practice. Must have accountability. There must be a clear responsibility for AI outcomes. We cannot say AI did this, right? Developers and deployers must be answerable for consequences. We have to address disparities and promote fair access, right? And proper governance, oversight, regulation. That's what we are talking about. Once you deploy it, it's not that you have deployed it and that's that. No, it's a continuous, it's through the life cycle. Okay, so hearing that, what are some of the strategic recommendations for Jamaica? Well, the first thing is that we need to establish a national AI ethics committee. So either we establish that or we train the ethics committee we have now to be able to deal with AI. It's one or two, right? The thing about it is that it's probably going to become overwhelming, but we have to have some sort of AI ethics committee. Even if it's a subcommittee of your ethics committee, we have to have people who are dialing down into that. We need to develop AI-specific healthcare regulations, and we can align them with the WHO principles. We don't have to reinvent the wheel, but we need to have specific AI healthcare regulation. We have to invest in workforce training and capacity building. If we do not do that, right, the healthcare workers that are now growing up in an age of AI, I didn't grow up in an age of AI, so I'm seeing these things. But for the young one, the Gen Zs and the wherever they reach Gen Alpha, whatever, I can't keep up. For those people, they are growing up with this as part of life. And remember, they may not see anything wrong with it. So we have to invest in workforce training and capacity building. We have to create data governance, a data governance framework protecting patient privacy. So yes, we have the Data Protection Act. We need to look at it now. How do we need to encompass AI? And it has to be an ongoing thing because AI is evolving. We can pilot some AI projects, in priority areas, diagnostics, disease surveillance. The truth of the matter is, we just didn't have it, but it's a missed opportunity. If we had this up and running, you know how much data we could collect from post-Melissa to help us prevent another damage like we got from Melissa. Not only would it be useful for us, but as a general fund of knowledge, right? So diagnostics, disease surveillance, I see those two areas have been easy for us to start with, right? Foster regional collaboration and knowledge sharing. It makes no sense in small island countries that we are trying to do this one is trying to do that one is trying to do that. We need to go regional, right? And the thing about it is, you will have other persons with similar populations, so we can gather that data. What would be ideal, is if we developed our own AI system, say for the Caribbean, right? That is trained on models, trained on data set from the Caribbean to help and the specific things that we face. That would be ideal. What may be even more ideal, of course, that thing, is that if each, say the Ministry of Health, had its own AI. So that AI is only dealing with Ministry of Health, right? So any data, whatever, not going anywhere else, Ministry of Health. But that's utopia, but still, let us look, regional collaboration, and ensure equitable. The thing about it, we have to make sure that AI doesn't perpetuate disparities in health. And it can. It can if we do not do it properly. We need stakeholder engagement. We can't just say, okay, this is what we want to do. Healthcare professionals, training, education. I think healthcare professionals need to be involved in the AI system design. So if we are going to design, and I think we have the ability in Jamaica to design why we don't have it? We could do anything. We have the ability. Healthcare professionals should be involved in that. Patients, a lot of times we do not look at the patients as stakeholders. We must have public awareness campaigns and participatory consent processes. Policymakers, evidence-based policy development, regional coordination, researchers, ethical, can I say it again? Ethical research protocols. Do not upload your data set into AI. Do not upload your finished whatever into AI, right? Data sharing agreements, we have to look at that. And report your AI use, how you used it, when you used it. Implementation roadmap, phase 1, establish governance structures and a regulatory framework. Conduct needs assessment and priority setting. Phase 2, launch pilot projects in selected healthcare facilities, develop training programs for healthcare professionals. Phase 3, scale successful pilots nationally. Most importantly, continuous monitoring and evaluation. So in conclusion, key takeaways. AI offers transformative potential for health research and care delivery because it translates to that. However, we must be aware there are significant ethical challenges and it must be addressed proactively. WHO principles provide a robust framework for responsible AI development. Jamaica can leverage AI to improve health research while protecting patient rights. And success requires multi-stakeholder collaboration and sustained commitment. These are my references. Thank you. Any questions?
Let us give another round of applause for Prof. Edwards. At this time, we're going to open the floor for questions. Are there any questions for Prof? I see a question here. Please go ahead.
Thank you. Good afternoon, Professor Edwards.
Hi.
Excellent presentation. I must help you tell you that you have 947 persons online.
Oh boy.
And you have a class waiting for you to teach them about research. The request is on there, so I have told them they can ask you. So it's an excellent presentation. And we are really appreciative of the way you make it so clear to us and relatable. The question that was on my mind while I was listening outside on my laptop, I said to myself, how are we going to now navigate the area of having our own indigenous AI? And you did answer the question. Because when you look at some YouTube, you hear some AI talking like Jamaicans with Jamaican voice. I'm not sure if any of us would have seen that. They speak patois as well. AI speaking patois and talking and interacting and telling them, Daddy, why you do this to me, and so and so. I say, Lord have mercy. So, but the concern there, though, is if we now get excited and we put everything that we own, we try to have our own. I'm thinking of what about the scamming? What about the hacking? What about the mining of data to take it elsewhere? Because once they have our information on the system, it is already there. So that is one of the clauses that makes it.
Yes, it is. And remember I say, I'm not uploading any of my data. But when I say if Jamaica develops AI. I am not an expert in that. I would expect that the persons who are developing will be able to put things. But I know people's cybersecurity is a big thing. It can be hacked. It can always be hacked. So it is something that we have to think about, right? Because as I said, the big thing, is confidentiality and privacy. And when, things are hacked, you don't know where is it going. It can be sold to a third party. What are they going to use that information? And as I say, people can run analyses and come up with results that they then use. And that's the big thing about AI. You have to be careful that we don't marginalize groups of people based on these algorithms. And that black box for me is very concerning. Because I don't know, how did AI come up with this output? And can I use this output? That's why I'm doing my own analysis. But that's me. But I'm not going to say, hold back the progress. What I'm saying, we have to look at how we move forward. And we must do it ethically. And remember, one thing I say, you will always have AI or no AI. You will have unethical people. AI is not what making you unethical. Because remember I started off about integrity? Right? As a researcher, right? If you have integrity, there is no tool that can make you do whatever. So what we have to look at is that education I told you about, because the young people are growing up. Let me just give you an example. They are growing up thinking AI is fine. Right? I'll just give you an example. So when we were, and I'm dating myself, when you're doing GCE, CXC, whatever, and you didn't read the literature book or the night before, you go to your Spark Notes or your whatever, and you're running through your Spark Notes, man, because you now read over the book. These people are going to ChatGPT. Give me a summary of the book. Right? And they don't see anything wrong with that. But what I saw, there was a play, and they asked for a summary. I know the play. I said, no, this is not the play. But there it is, ChatGPT gave a lovely summary, and all the characters, and blah, blah, blah. And it wasn't the play. Right? So the thing about it is that education, because people are going to be coming up, AI is going to come, like, for instance, when I tell my daughter asks me, oh, so when you were at school, you used to call your mother to come for you? I say to her, listen, girl, we didn't have no cell phone there. And she's like, so then how did you communicate with your mother? I say, I went to school, and I just stand up in the schoolyard and wait till she come. Not at 2:30, as soon as school is finished. Where are you? I am working. I am working to be able to pay for the things you want. Your cell phone being one. So they are growing up. They don't think anything about going to ChatGPT, So we have to put the guardrails. And it makes no sense but us saying, don't use it. No, no, no. Because you're putting your head in the sand. What you have to do, what we, as researchers, as educators, as whatever, we have to put the guardrails. This is the way you use it, responsibly, ethically.
So we'll take probably 2 or 3 more questions, and then we'll close the session.
It was noted that students should learn traditional research methods rather than jumping into AI. In addition to traditional learning, are there any courses, programs, or mentors in AI, perhaps focusing on health, software, etc., that you would recommend at this time to supplement traditional learning for data cleaning, analysis, etc., for not just students, but also for all stages of professionals in order to not get left behind?
Yeah. Okay, so when I said that, it doesn't mean, so what you hit on, they should have someone walking them through the process. So, okay, why I said I want my students to know how to do a literature review, right? Now, you stand if you just allow them to go into AI. You run the risk that they ask AI to summarize those papers. If we are going to use it, I'm going to walk them through it. So we say, okay, we're at the brainstorming stage. Okay, when we reach the literature review, they have to come to me with their list of things. And a good old-fashioned way, you have your spreadsheet, right? You have the year, the authors, the year, number of participants, methodology. What they have to come and show me that. So, okay, they may use it to get to a certain point, but what I want to make sure is that they are not using AI to just do, and they will do that. I'm sorry. I apologize for the students who say they won't do it, but there are students who would do it. They would say to AI, summarize this for me, or write a literature review. So maybe let me just modify what I said. If they are using it, they must have oversight. It's not that they are going. So they have to bring it to you and show you the spreadsheet where they have gone through. They have to show me their version of when they wrote their literature review. Remember I said have versions? So I need to see the first one. I have made the corrections, second one, etc. So you can teach them to use AI responsibly, and I take that point. You know, don't just not teach them, but you have to ensure that you're teaching them how to use it responsibly. I don't know personally of any courses, but I'm sure there would be some out there. There must be some. But if we are teaching the students, you are holding their hand and walking them through and saying, okay, I want to see. What is your aim? What is the aim? What are the objectives? Are the objectives aligned with the aim? You know? What is the methodology you're proposing? Okay, if this is a methodology, do you think, how would you, I look at your questionnaire because you're going to make your questionnaire. You're not going to ask AI to do a questionnaire. So I see that first version, I go through it, I say, but based on this questionnaire, you're not going to be able to achieve objective 2. Let's go back. So I agree with you, we need that. All of us need it, right, to be able to go forward using it responsibly.
I have 2 more questions for you.
Mm-hmm.
Are there any legal or ethical frameworks, example, similar to plagiarism policies, that researchers should follow to attribute AI contributions without compromising intellectual integrity?
Okay, so a lot of the ethical bodies are working on, so like SIOMs, and they are working on AI, how to use it, how to report it. So I know there's a lot of work going on. I think PAHO, it may have something that they are working. I know there was supposed to be a workshop that got put off because of Melissa. And I haven't seen it. I've been waiting for it to go to that workshop because I think they are working on some guidance. So yes, so you all can look out for that workshop. PAHO had it, it was to be around the time of Melissa. And they've put it off, so you can look out for when it's coming and make sure and go to that workshop because they are developing guidelines.
Last question.
Oh, she has one more.
How can we make sure patients and their families really understand AI's role in their care decisions?
Well, you know, that's $1 million question. It is, because that's part of the problem. How are they going to understand? And how in that consent form you're going to give enough information for them to understand and voluntary. That's a big, remember I said the consent, because for them to understand AI, to understand, as I said, we have to come up with how much, I don't even want to say autonomy, but how much autonomy do you give AI in medical practice? That is something that Ministry of Health, different stakeholders have to sit down. Because remember I said there's a liability issue, you know. So if I cannot say as a medical practitioner that there was this AI-enabled tool at the hospital that when it went through, this is the diagnosis, but it turned out to be erroneous But I am not taking responsibility for it because it's the AI too. AI doesn't have moral, and that's why I said it's a tool to optimize. It doesn't take away, your human oversight. So as a doctor, even if it's telling me that's the diagnosis, I still have to go to my history, my examination, my investigations, and see. Because that black box, but it's $1 million question. It is.
Thank you.
Sure, man. Thank you.
And so we want to thank Professor Trotman Edwards for such an excellent presentation. It was truly a master class. And it has given us a lot of food for thought. I think one of the things that reverberates throughout her presentation is that of our own personal responsibility, that we cannot give it away to AI, and so we have to be responsible for what we do and the research that we do. So thanks again, Prof, and we hope that you will be able to come again for another conference. Thank you very much. At this time, we will be closing this session and we will be going to our lunch break. Thank you.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccine
Good afternoon, ladies and gentlemen, and welcome to our first workshop at the 16th National Health Research Conference. I'm Ardeen Harris, and I'm a medical epidemiologist in the National Surveillance Unit, Ministry of Health and Wellness. And today we'll be looking at improving our abstract writing skills. And to lead us in that, we have with us Dr. Daniel Thomas. Dr. Daniel Thomas is a medical doctor and junior research fellow at the Tropical Metabolism Research Unit, that is in the Caribbean Institute for Health Research at the University of the West Indies, Mona. Dr. Thomas is currently a PhD candidate in human nutrition at UWI with a focus on plant-based nutrition, in particular protein quality, highlighting its role in the dietary management of diabetes and heart disease. Dr. Thomas received a Queen Elizabeth Scholarship for training in innovative approaches to diabetes prevention and control at the University of Saskatchewan in Canada. He has a passion for promoting wellness and empowering others to make healthy lifestyle choices. Dr. Thomas enjoys studying languages and is a travel aficionado. Let's make him welcome.
Thank you for that warm welcome. All right. I have to adjust the mic a little bit. How are we doing? Okay. All right. So if I walk around the stage, how will that work? In terms of, I have to stay here. All right. No problem. Okay. So today we are going to be speaking on the fundamentals of abstract writing. And we have about half an hour to go through. I see that there are some familiar faces in the room from the ministry. How many do we have online currently? Okay. We have wow, okay, that's great. So we have a lot of people, 794, interested in writing abstracts. Okay. Could I have a poll put out for the viewers? I want to know who, just yes or no, if you've ever written an abstract. That's a simple yes or no, just to get an idea of what type of demographic we have in the audience today. So here, if you've written an abstract before, can I see a hand? All right, great, so half of the room. And if you've never written an abstract, that's the other half. Hands up if you don't know what an abstract is. Okay, so everybody knows what an abstract is. What's the poll like in the chat? How many people have written an abstract before? Okay, so my work here is easy. Okay, so as Dr. Harris said, Dr. Arden, my high school. So yes, I'm a junior research fellow. I'm a junior research fellow. So per se, I'm not necessarily someone who's written many papers and many abstracts, but I'm very, very familiar with the concept of having to write an abstract. You know, for these journals or for our events like these, where we have to present on a topic, you have to write an abstract. And going through the field of research, you'll become very familiar with the need to write abstracts. And so today we just want to speak about the importance of it and some tips about how we can effectively write an abstract. Okay, so first thing, we're going to talk about what is an abstract, what's the importance of an abstract or the value in medical or scientific research. We want to talk about some essential components of an abstract, and then we're going to discuss some key strategies to summarizing your research to create your abstract with a few examples. Okay? What was the poll? Half and half? 60%, 40%? 90%, 10%? Have written an abstract before. Okay. All right, perfect. So I guess most people are on just to solidify certain concepts and to improve on their abstract writing. I find that for me, writing an abstract always seems like a daunting challenge because, I mean, you've written them before, but you always want to improve in how you write them. You always want to be more efficient in how you write them. So let's go through today and let's see how we can all improve together in our abstract writing skills. So an abstract is a synopsis of your research study. So it's a concise summary of your research. And it's a tool that you use to communicate the important findings of your work in a succinct manner. An abstract of 250 words may be read in about 1 to 2 minutes. So it's a brief summary, a snapshot of what you want your reader to what you want to impart to your reader. Why is it important? Okay, so let's talk about this in two facets. You might have to submit an abstract to a journal or to a review board or to a conference to be accepted for your work to be published. And then you also have the aspect of where the reader is reviewing your work because they want to, say, do a literature review, or they're trying to do a scoping review, a systematic review, and they want to ensure that your work is pertinent to their field of study. So let's look from the aspect of you're applying to a conference like this. You have to submit your abstract. In the first 1 or 2 minutes, you have to convince the reviewer that your work is important enough to be showcased at an event like this, okay? Or you have to convince the reviewers that your work is worthy to be published in their journal, right? Or if you're applying for a grant, they have to see that within your abstract, your work meets a tier that makes it eligible to be funded or to go to the next stage of reviewing the entire article. Because when these reviewers get 100 or 200 or 300 abstracts to go through, they're not going to be going through everybody's paper. They're just going to be going through your abstract, okay? So in that 1 to 2, 250 words that they give you, within that 2 minutes of reading, it has to be punked. It has to give enough bites or enough punch for them to say, okay, we can choose this, select this one, and then go to the next stage of going through vetting the entire paper that you've published. And also for the person that's trying to, people in here might have done a literature review before, or they've done a scoping review before, and you're going through 100 articles, 200 articles, you're trying to sift through, right? You're sifting through the mine. And you're just going to look through the abstract, first of all, to see if what the writer has communicated in their abstract is worthy enough or of your time for you to actually download this article and read through the article, all right? So the abstract is the first point of interaction between your manuscript and the reader. Again, also for some databases, downloading the abstract isn't free, right? So if I'm going to download your paper, your abstract has to convince me that it's worth reading, worth my time. All right, so in terms of abstracts, we have basically two broad categories. We have structured and we have unstructured abstracts. A structured abstract is the ones that we might be more familiar with, where we have our different subheadings. So we have our introduction, our methods, our results, our conclusion. And the unstructured is basically the same thing, it's just that we haven't broken it down by those categories. So they should both convey the same information, just that the structured one has, as it says, more structure. The word limit. The dreaded word limit. Do I hear a groan? All right, I think this is probably the hardest part of abstract writing, because your paper has so much information in it that you don't know, it's hard to condense it all into 250 words, 200 words, 300 words, right? And I think that's the art of writing a great abstract. It's the art of being concise and the art of being able to select from your work what needs to make it into that 250 words. But let's look at it, 250 words. So 500 words to a page, which means 250 words is just basically half a page. All right, and some of us have papers, manuscripts that are 10 pages, all right? How do we summarize 10 pages into half a page of work? So we're going to look at some tips of how we can do that in the next couple of minutes, all right? And if 250 words is the amount, and we're going to break it down into a couple sentences, if we're doing 15 to 20 words per sentence, we have about 13 sentences in total to convey your abstract, all right? So we are breaking down your work into 13 sentences to convince someone to publish your work, to accept your work into their journal, into their conference, to give you money for a grant. All right, so let's look at an anatomy of an abstract in a simple skeleton form. So let's say for a 250-word abstract with 13 sentences, this is how you probably want to break it down. So the results section will always usually get the most of your time. It's going to get about 5 sentences out of your 13 sentences. And then the intro and the methods, the intro will be the shortest, usually, 2 to 3 sentences. And we can say the method will be about 3 sentences. And the conclusion, 2 to 3 sentences. All right, and that will give us your total of 13 sentences or your 250 words on most abstracts in a 250 word limit. Okay, so when you think of your abstract, think about, I need 2 sentences for my intro, I need 3 sentences for my method, 5 sentences for my results, and 2 to wrap it up. Okay, and then it kind of takes the mystery away, and you say, okay, well, let me find my 2 best sentences for this, my 2 best sentences for that. All right, so sometimes we want to write the abstract first before we write the paper. That's not usually often recommended. Usually we have our paper first, and then once you've written our paper, you write your abstract, all right? But sometimes you might feel inspired because you've done some research, you've gotten some data, you have some results, and you want to write this abstract down. It's no problem. Go ahead. But know that it's just a draft. The results might change, the interpretation might change once you actually flesh out your whole paper, and you'll have to rewrite the abstract. But it can also sometimes inspire you to write your paper once you have your abstract down, and it can kind of guide you. But usually, we have our paper, and then from our paper, we go through and we write our abstract. All right, so let's look at some strategies of how we can start putting our abstract together. So the first step is really discovering the most important message of your paper, of your manuscript. And I have 2 approaches to propose for us going forward. I mean, there might be more, but these 2 you can try. If you have trouble with your abstract writing, you can try these approaches and then see how they work for you. So the first approach I'm going to propose is, first you read through your entire paper. So you have your manuscript, you've written it, you know what's in it. So you read through your whole paper, okay? And then you put it down. And then you step away from it, and then you write down what you think the key messages are in about 5 sentences, okay? So what that means is that key message is what you want your reader of your abstract to take home once they've read your abstract, all right? Approach 2. Let's say you're being interviewed about your paper, right? You're on CNN, TVJ, and they're asking you in 3 minutes. You guys know about the elevator pitch that a lot of us do in graduate studies? So this sounds like an elevator pitch, right? It's saying in 3 minutes, how would you, in your thesis, how would you summarize your abstract for a viewer so that they can grasp the gravity of it all or the importance of it all in 3 minutes, okay? So you might say, thank you, whoever. My work focused on ... I found this and that, and this is important because this and this. And from what you say to that interviewer, you record yourself on your phone, make a voice note, or videotape yourself if you want to, right? But in that 3 minutes, you basically summarize the essence of what you want your viewer or your reader, to gain from your abstract. And that will kind of guide to ensure that whenever you finish writing your abstract, if that main message is not delivered in your abstract, then you probably missed the mark for your abstract, okay? So let's look at some keys of how we can create our outline for an abstract. So I have 2 approaches again, and the first one is, they're pretty similar, but the first one is, again, you're going to read through your paper. All right, so you have your paper, you have your introduction, you have your materials and your methods, all right? You have your results, you have your discussion, you have your conclusion. And what you're going to do, you're going to go through your paper and you're going to highlight in each section the important parts of each section, the most important sentences of each section. So you go through your intro, you highlight your important standout points in your intro. You go through your method, you highlight the important parts of your method. All right, you go through results, you probably go through your tables, and you try and summarize, right, the important ones in that. Same thing in the discussion. What were your salient inferences? What were your implications that stood out in your discussion? And you highlight those. And then what you can do after that, you synthesize those, and then you'll have to whittle down eventually to get to your word limit. The next approach is you go through each section of the paper, and you do this similarly, but you're going to summarize instead. So you go through your intro, each section you summarize 3 sentences, go through your method, summarize 3 sentences, go through your discussion, summarize 3 sentences, etc., okay? And in that way, you've basically made an abstract for each section, and then you can, from there, decide what you're going to put in your final abstract, okay? And for the results, you can probably go through the tables, each table, and for each table, you might want to write a 1-sentence summary of what this table is saying, what the results are saying, what were the key highlights from this table. You might have 3 or 4 tables in your paper, So you write one sentence on each. And then you can decide which is the most important result that you eventually will want to put in your abstract. All right, so let's go to the different parts of the abstract. Let's start with the introduction or the background. And the introduction is, as we said, very important because it's supposed to grab your reader. All right? When you write your first 2 sentences, the person's going to decide, unless it's something that they're very interested in, the average reader is going to say, this is not for me. All right? They're going to say, no, this is not very interesting. But sometimes you have when someone is making a trailer for a movie, the first 20 seconds have to grab you or you're not going to watch the rest of the trailer, right? So your intro is basically your trailer for your abstract. Okay, and if your trailer doesn't grab the reader, you lost your window of opportunity. Okay? So it's supposed to be short, succinct, and it should still be impactful that the reader will want to read. What did you do? What did you find? What did they conclude? So as we said, the intro will be about 2 to 3 sentences, and you want to save space for the rest of your abstract. So you don't want to be writing a whole epistle for your introduction. You might be keen to write a lot of background because you want them to understand the importance of your topic, but you still have to figure out how to summarize that importance into one sentence, right? Because usually it's usually an introduction and then you aim, right? So you do a little background with, say, red is the most important color in the universe, but because we don't know how much people wear red in Jamaica, we decided that this needed to be studied, yada, yada, yada. Aim, all right? So you let people know how significant your study is without overemphasizing it, and then tell them what you did. That's usually what's in the intro. All right, so I have here some examples of a couple papers that have different abstracts written by many, you might know the authors. I'll actually share at the end, but I'm just going to go through them so we can get an example of some intros and some results, some method sections of each section, okay? So as I go through each section, I'll go through a couple examples for each. So here we have the paper on the prevalence of major potential drug-drug interactions at a university health center pharmacy in Jamaica. And you see for these 2 papers that they only had the aim or the objective. They didn't really have much of a background, which will depend on your journal. Your journal might say they just want an aim, they just want an objective, and obviously you'll follow those guidelines. So here they have very simply one sentence. To identify major potential drug-to-drug interactions on prescriptions filled at the University Health Center, Mona campus. Okay? This other study here by some surgeons at UWI looked at the comparative analysis of open and laparoscopic colectomy for malignancy in a developing country, and they wrote their aim. To compare short-term, including oncologic outcomes of open versus laparoscopic colectomy for cancer in a developing country. All right, so to the point, right? Don't beat around the bush, tell them what you're doing, and move on. Now, this group obviously had a longer word limit because they went to town. So they give a little bit of background and they gave you their aim. So in this study on elevated blood pressure and illness beliefs, and they stated it's a cross-sectional study of emergency department patients in Jamaica. So they gave us a little background. Elevated blood pressure is common among emergency department patients, and then they showed a gap. While some data exists on association between emergency department blood pressure and hypertension, in the USA, there's little known about this relationship in Afro-Caribbean nations. All right? And then they go to their aim. The aim of the study was to evaluate the relationship between BP, etc. All right? And they also looked at some socioeconomic status and different variables between people that they studied. So, following, right? We see the scheme. We have our aim, and sometimes we have a little bit of background before, showing some gaps and the importance of the work. All right, so the next section is the method section, and this is usually about 3 sentences. Okay, so we had 2, 3, 5, 3. So in the method section, we're going to state key techniques that were used. All right, we're going to look at population studied and where the study was done. Things that you want to include are also like the sample size, patient groups. If you're given medication, we'll look at dosages, the study duration. If it's like an interventional study, look at the surgical management that was offered or the medical management. And you also want to comment on the study design. A cohort, a cross-sectional, a case control, And in basic medical sciences, you want to say, was it an experimental design? A couple important questions for clinical studies. As similar to the slide before, what was the research design? What was the clinical diagnosis of the patients recruited? What was the setting of the study? Was it in hospital? Was it in a research center? Was it at home? Did you visit the homes? What was the sample size of the whole study? And sometimes you break your participants into groups, so what was the sample size of your individual groups, your Ns? And what treatment did the patients assigned to the different groups receive? What doses were given? Instruments used to rate patients, different scales that were used? And what was the primary outcome measure, and how was it identified? So even though it's 2-3 sentences, it still has to be very informative, all right? So what I like to say about abstracts is that you're paying for each word that you write. So, you know, when they say, can I buy a vowel, you know? You have to imagine that you have a bank that you have to pay for each word. You have to make sure that each word that you just choose to put in each sentence is not there just to take up space, all right? Because you only have 250 words, and you have to get all this across in 3 sentences or 2 sentences. And it comes with practice. I mean, even me, I'm still a junior, right? I'm still a junior. But the more that you practice, the better you get at it. And the more that you work at it, the faster you get at summarizing and being able to be more succinct. So the prevalence of major potential drug interactions, we spoke about this before, but the methods now, what did they do? So the investigation utilized a cross-sectional analysis of all the prescriptions with more than one drug that were filled. All right, so this is what? 1-2 sentences, all right? What they did and how they did it. Okay? The next one, the one about laparoscopic colectomy on looking at malignancy outcomes. So this is what? 1 sentence, 2 sentences, 4 sentences, all right? So they looked at the records, looked at the demographics, right? They looked at findings perioperatively and postoperatively, and then they looked at the statistics, all right? 1, 2, 3, bam, methods, okay? So it's about getting your points across very quickly while still being detailed in how you bring it across. The third one we spoke about, they said cross-sectional survey, time period 6 weeks, right? They said when they did the study, right? They described the participants. Those surveyed were non-critically ill or injured adults, emergency department patients, age, all right? Where? Afro-Caribbean hospital, all right? Then they spoke about the statistics that they would do, and they didn't say significance here, but yeah, the one before showed P values, that's in the methods as well. Results. So the results are your longest section. You know, you can go to town on your 5 sentences or your 6 sentences here. But you still want to make sure it is the most important or the most impactful results. All right, this is what you want the reader to go home saying, wow, this is interesting. Because sometimes all you're going to see about somebody's paper is their abstract, you know. I mean, sometimes you're citing people and you're citing them abstract because you never read the paper. So if the results really has to show a good sense of what you published in your work, because sometimes no one will ever get around to reading your full published work. So it should be the longest part, and it's the most important findings only. So we're going back to our CNN interview, or TVJ interview, where you say, what were your most important findings, and what do you say first? That's usually what you say in your results. Okay? So for example here, this example here, the average weight gained in these frog dolly rats in group A versus group B was this versus that, and the significance. That was probably a key take home here. Yep. I have here that it's important to note that because you state the p-value, you don't really need to state significance, right? Because it implies it. So you want to not be repetitive in how you write any section of your abstract because you're short on words. Okay, most readers will understand what you're trying to say when you state your p-values. So try not to be repetitive or redundant when you're writing your abstract. I mean, when you're writing your paper, you don't want to be repetitive or redundant, but you have more leeway. because you don't have a word limit. Okay, so let's look at these examples here. The prevalence of major potential drug-drug interactions, same paper, same 1, 2, 3. Let's look at some of the results. So during the period of study, a total of 2,814 prescriptions were analyzed for potential interactions. And then they reported on the prevalence of interactions, reported on the major and minor and moderate potential interactions, right? And they report on the 3 most important interactions that they identified by looking at all of these prescriptions. Okay? Clear, right? I mean, right? We can all do this. This other one here, the one on laparoscopic versus open colectomy. So the surgeons reported that they looked at 87 cases, and they didn't find much significant difference between the open versus the laparoscopic groups, okay? And there was a trend, they described the trends, and they described the findings, and then they looked at morbidity and mortality between the two, which is what they were looking at, all right? So that's how they report the results. This one looks like 6 sentences, right? So you see that they're still falling within that ballpark of sentences to each section. And in the last one, we look at the blood pressure in the emergency department. Similar thing. They reported how many patients. They looked at some of the statistics that were done, look at the comparative between the results, their most important results, share their p-values again, right? And then among those with a history of hypertension, right? So they're looking at what they're in their method section. They're trying to show the most important results from what the methods was supposed to find. Okay. All right, our conclusion. So the conclusion is your last 1 to 2 sentences, and it's devoted to your overall take-home message. So let's go back to our interview. What did your study reveal? What did you conclude? And the results provide evidence for. So you want to state your implications or your inferences in that conclusion. Important note, even though you want to state your implications, you don't want to overstate your conclusion. Sometimes you've done a study and you feel this is the most important study in the whole universe, right? You think that this is going to bring world peace, right? It's going to serve world hunger. But usually your study cannot, right? It has to be a large series of studies, probably by a huge group of people working together for that kind of impact. So don't try and say that our study found this conclusively and we are sure about this, because it's usually not the case. All right, so don't overstate your conclusion. So for example, here we have 2 conclusions. One is the prevalence of COPD was higher than reported, and healthcare practitioners should be trained in identifying common symptoms of COPD. Versus the second option, which is my sample of 20 clearly demonstrates the need for a retraining of all staff in COPD identification, right? So we see that the second one is definitely too confident in their results and needs to probably tone down how they've written their conclusion. All right, let's look at a couple of examples. So the prevalence of major potential drug interactions, let's look at their conclusion. So they share that their study highlighted the need for educational initiatives to ensure that physicians and pharmacists collaborate in an effort to minimize the risk to patients. And these interactions are avoidable for the most part, as online tools can facilitate selection of therapeutic alternatives, etc. So they state their conclusion and they put an implication or an inference to sum it up. All right, let's look at the other one. So the surgeons here said that laparoscopic colectomy in a developing country is oncologically safe and represents an option for colonic malignancies in these regions. So that's their conclusion. What they're implying or they're inferring is that such data encourages the continued laparoscopic development. All right, this is probably a very old study. All right, and this final one on elevated blood pressure in the ED. So they said that their single center study showed that 2 out of every 5 Jamaican patients have elevated presenting BP, the majority of whom had a previous diagnosis of hypertension. All right, so that's their conclusion. What are they implying or they inferring? Further studies should evaluate if brief interventions provided by the emergency department team will improve hypertensive control in this patient population. All right, so you've seen the pattern here of how you state your conclusions. All right, so the journal requirements. Most journals will provide clear instructions to authors on the formatting and the content of the different parts of your manuscript. And this will also usually speak to the abstract. And authors should therefore tailor their abstract to the requirements of the journal that you're applying to, because they won't even give it a second thought if you don't follow their instructions. Right? And a tip that you can probably use if you're applying to a specific journal is to find an abstract in that paper that journal you're planning to publish in. Find a good abstract. And then you can model your abstract off of that abstract. So you can use it as a template to create your own abstract. So you can look at their introduction, how did they create it? Did they do their background and then their aim? Or did they just put an aim, right? Their method section, how many sentences were in their method section? How many sentences were in their results section? How many sentences were in their conclusion? And you kind of mirror it based on what is in that template for you. All right? I mean, if you go in a journal, you're going to see a million articles that you can choose and refuse. You might not like someone's writing style. You find someone whose writing style is more akin to your own. All right, so in summary, the abstract is the only part of the paper that most readers will ever see. All right, and it's the first point of interaction with your manuscript. So it should be as detailed as possible within the word count limits specified by the journal to which the paper is intended to be submitted. And it's critically important for authors to ensure that their enthusiasm or bias does not seep through to deceive the reader. All right, so unjustified speculations should be avoided, as they could be even more harmful. Okay, so I can provide these references. Probably we can put them in the chat so people can download and read them at their leisure. But that's it for me at this point. So thank you for your time. And happy abstract writing to you all. Thank you.
Thank you so much, Dr. Thomas. So I know we have a few minutes for question and answer. Is there any in the room or online? Remember, 250 words, thereabouts, or based on the guidelines, must be read in 1 to 2 minutes, maybe 13 sentences or so. So I know we're well on our way to preparing abstracts for the next NHRC or for journals, you know. I know we learned something, but any questions or comments? None online? Waiting to hear.
There aren't any questions, Dr. Thomas, but persons are just expressing thanks for the presentation. They're saying that the pointers are useful and that your presentation is engaging and very relevant, simple and easy to understand.
Can you just comment on the titling in your abstract? Titles, yes, abstract titles.
Okay.
Because there are several philosophies about titling. Can you just comment on how you would think of a nice title for your abstracts?
Okay. Well, in terms of the schools of thought, so normally the abstract title will follow the manuscript title. So do we think about it from the fact that how do you decide on your manuscript title to begin with? Because I know in some of the papers that I've attempted writing, you want your title, first of all, to also grab, right? So we spoke about the trailer, the trailer for the movie. Your title is also the trailer for your paper or your abstract. So you might want to be a bit, I think some people are more creative in how they write their titles. I try to be more creative because you want people to actually be excited about the topic that you're going to write about. And I find some titles are sometimes dull, which is not bad in the scientific community. Not everybody is very creative or excited. But for me, I try to be not per se concrete with the title, but to actually invite the reader to want to know what I'm going to speak about by having a title that will attract the reader. But I'll take also any comments or suggestions that's on the title from Prof.
Oh, no.
Okay.
Again, just like you ended your talk, one has to read the instructions to authors.
Right.
To help you guide you what you're tackling.
Yes.
So some conferences and some journals insist that your title should be a statement.
Okay.
Some will allow you to put it in the form of a question.
Okay.
So the first part of it, or the first part of that answer is check with the instructions,
Okay.
right? And see what it is that they would wish the title to be. Some will also restrict in the number of characters that you're allowed, all right? But typically, we get the gist of your title from the main result or the main message that you wish to convey. So your title is another opportunity for you to communicate with your readers what you want the abstract to focus on. What is that main message?
Okay.
So once you have that main message, you look at the number of characters that you're allowed, you look at the instructions that the journal or the conference people have given you, and then you frame it within those limits.
Awesome. Thank you, Prof.
All right, thanks for the questions and the comments. And I know it has been very useful for me and to those online, and by virtue of not having many questions, I'm sure it was quite clear. So with that, we're going to close out our abstract writing workshop and thank Dr. Thomas for presenting and invite Ms. Mullings to come to us for our conference fun segment.
Called cancer at the age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated.
Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
Good afternoon, ladies and gentlemen. Welcome to Conference Fun. I am Tennille Mullings, and at this time, we're going to ask you a few questions based on the presentations we've been having over the last 2 days. Today's our 3rd day, and we are asking that you SMS text your answer to 344-3204. 344-3204. Yes, SMS text message, please. All right, here we go. Question number 1. All right, let's go with the number again. 876-344-3204. Our first question. How many award tiers are there for the Research for Wellness Fund? And name one area of wellness for the award. Question number 1. How many award tiers are there for the Research for Wellness Fund? And name one area of wellness for the award. Question number 2. What was the research area Dr. the Honorable Christopher Tufton highlighted in relation to youth? Question number 2, what was the research area Dr. the Honorable Christopher Tufton highlighted in relation to our youth? Question number 3, what is the declaration of the 1978 Alma Ata Declaration? Question number 3, what is the declaration of the 1978 Alma Ata Declaration? So now we're going to question 4. What is the name of the mental health intervention highlighted by Professor Wendell Abel? Question number 4, what is the name of the mental health intervention highlighted by Professor Wendell Abel? So remember, we're texting our answers to 344-3204. So now we're down to the last 3 questions. So you have 7 opportunities to win a prize from the conference. And of course, we have the leaderboard prizes as well. Question number 5. What is one of the promises of AI in health research as stated during Prof. Trotman Edwards' presentation? Question number 5. What is one of the promises of AI in health research as stated during Prof. Trotman Edwards' presentation on AI and ethics in research? Question number 6. What was the name of our policy spotlight feature? Question number 6. What was the name of our policy spotlight feature? And ladies and gentlemen, our final question. How many health facilities are now operational approximately 100 days after Hurricane Melissa? Question number 7. So this was on day number 1. How many health facilities are now operational approximately 100 days after Hurricane Melissa? So we invite you guys to text your answer to 344-3204. We are waiting on those answers. So you can text question number 1 and you put the answer. Thank you.
it is fundamental now to gather the data, to assess the data, to use the data to make informed decisions. I want to commend you on the work that you have done and encourage you to continue in terms of the work that needs to be done going forward.
The National Health Research Conference, NHRC, is where science, innovation, and policy meet to impact the health and well-being of the population. This transformative event has been helping to shape Jamaica's healthcare landscape for over a decade. Following its inaugural staging in 2010, it's the flagship platform of the Ministry of Health and Wellness, uniting government institutions, academic minds, and the wider public to share groundbreaking health research that's pushing the boundaries of innovation and that can provide solutions to meet modern healthcare needs. The NHRC's key objectives are to facilitate the sharing of research findings from the various participating researchers, identify operational research with the potential to shape public health policy, and aid special discussions on the conference theme to drive actionable outcomes.
It's research that will have some impact on our operations, our guidelines, our policies. For example, we did COVID research and that helped shape our COVID response.
Since its inception in 2010, with a gathering of 80 attendees at the Pegasus Hotel in New Kingston, conference attendance has soared over the years.
The last conference would have seen 933 persons on Zoom and over 6,000 persons on social media. So it has grown exponentially.
The National Health Research Conference has seen stunning growth each year in the number and quantity of research abstracts submitted.
When we started out, with a few abstracts that would have been submitted, up to today where we have a large volume in terms of poster and oral presentations. The growth still continues to where our numbers have grown, and I'm very proud to be a part of that experience.
The National Health Research Conference awards presenters for high quality research in 3 categories for both the oral and poster competitions. And these are Best Overall Presentation, the Most Impactful Presentation, and the Best Student Presentation.
The systems that have been put in place has grown in strength, and the conference has likewise grown. And so the journey continues, but it has been a good journey.
Till the next conference, every 3rd Wednesday to Friday in November, this has been our peek inside the NHRC, with over a decade of transformative research shaping a healthier future for Jamaica.
Good afternoon, everyone. And we have come to the culmination of the 16th Annual National Health Research Conference. We have much to celebrate, and as usual, we want to specially recognize research excellence. The conference themes are to share findings of health research studies conducted by the Ministry of Health and Wellness and other institutions and individuals in Jamaica, to identify operational research with the potential to influence or be translated into policy, and to facilitate special discussions or presentations that focus on the conference theme. Hopefully, over the 3 conference days, we have been able to achieve these objectives. And so we invite your comments to place in the chat online if you think that we have achieved those conference objectives. But not only do we want to achieve the conference objectives and to present research, we want to have the research showcase that we believe will impact policy and practice. And as usual, we wish to celebrate our research award winners. And so each year we award our presenters in terms of 3 categories for both oral and poster presenters. So we have the best overall presentation, best student presentation, and most impactful presentation. We also want to invite our branch head, Dr. Karen Webster Carr, to come forward as she will prepare to hand out the prizes to the award winners. And so we begin with the best poster presentation. So I would like everyone inside, if you can just give a drum roll, please. Thank you. Better than a drummer. Thank you. All right, so we will begin with the best student presentation. And this is awarded to Dr. Pringle for the presentation entitled Intensive Care Capacity in Jamaica, a National Cross-Sectional Study. Dr. Pringle. Okay, so we understand that Dr. Pringle has not been able to make it as yet. Also to say that Dr. Pringle was awarded the most impactful presentation, and the most impactful presentation is that we believe will have the most influence in terms of policy. So let us give another round of applause. And then, in terms of the best overall poster presentation, I need another drum roll. Thank you. This is awarded to Dr. Williams for the presentation entitled Air Quality in Jamaica's Main Urban Areas, 2010 to 2023. Thank you. So we transition now to best oral presentation, or the winners for oral presentation. And we begin with the best student presentation. And this is awarded to Dr. Marcia Johnson Campbell for her research entitled Assessment of Delays to Diagnosis and Treatment of Breast Cancer Among Patients Accessing Care at the Cornwall Regional Hospital in Western Jamaica, a mixed method study. And Dr. Johnson Campbell, don't go too far. We also would like to award Dr. Johnson Campbell for most impactful oral presentation. And finally, and I need the last drum roll for this segment, we want to announce the winner of the best overall oral presentation, and that is Mr. Devon Keith for his presentation entitled Cost Effectiveness of Abemaciclib plus Endocrine Therapy in High-Risk HR plus HER2 Early Breast Cancer in Jamaica. Thank you, and thank you, Dr. Webster. And we'll ask Dr. Webster to stand by again at some point. Yes. Okay. So we transition from the award winners to our vote of thanks. So there is no break. We're just going to go straight into the vote of thanks. And I begin by sharing the words of a psalm, Psalm 136, which states, "Give thanks to the Lord, for he is good. His love endures forever." Can I invite everyone in the room to say that, please? Give thanks to the Lord, for he is good. His love endures forever. Let's say it one last time. Give thanks to the Lord, for he is good. His love endures forever. And so in the timely tradition of the Ministry of Health and Wellness and the National Epidemiology Branch, where we begin meetings by recognizing the one who is higher than ourselves, we also close this conference by giving thanks to God. I invite us to give a round of applause for what has transpired over the 3 days of the conference. It truly has been a wonderful 3 days of rich, timely, and informative presentations. Before we recognize specific individuals, we want to acknowledge that the successful execution of a conference of this magnitude is the result of the intersection of many moving parts. So if we think of a timepiece where we have several cogs working, there are several cogs working with respect to this conference. And so as one conference ends, we begin planning for the next. We normally begin by selecting our conference theme as well as the topics to highlight, and this is done by consulting the opinions of you, our audience. And that is why it is critical to complete the evaluation form, and so this is a plug that for this year, for those who have not completed the evaluation form, please do so, because we really do listen to you. When the abstracts, and then after that, we invite the submission of research abstracts for consideration. When the abstracts are submitted, we then have the task of adjudication, so that is prioritizing and selecting those that are going to be presented at the event. And we wish to recognize a team of adjudicators who helped us with this exercise this year. And if you are in the room, I would invite you to stand, please. We begin by recognizing Mrs. Stephanie Bernard Stevens, Miss Samantha Anderson, Mrs. Antoinette Patterson Bartley, Miss Romay Tharp, Miss Prudence Hall, Dr. Patience Alonge, Miss Deborah Henningham, Dr. Sharon Dawson, Mrs. Tanil Mullings, Miss Lisa MacDonald, Dr. Shelley McFarlane, who we know is overseas, Dr. Carol Lord. After the abstracts are selected, we then have to begin thinking about our platform and how we are going to present them virtually. And there are two very critical teams who each year have been assisting us with this event. We want to recognize the VFair, our virtual fairs team, and we specially recognize Mr. Wasim Akram, Mr. Ahmed Ikitar, and Mrs. Sharmeen Ajmal. And then the other team, many of them are in the room, and they are the team that make us look good. And that is our main partner, which is the Jamaica Information Service. We wish to specially recognize the television and Zoom teams, as well as the production team, which had helped us with our conference booklet. But we want to specially recognize someone. She's going to be surprised. But we have to say a very special thank you. She gets the quarreling, but she also gets the commendation. And that is Miss Peter Gay Hodges. Dr. Webster, can you come forward, please? And before she goes, I want to get the hug, because she gets the quarreling, but she also gets the commendation.
Thank you so much. Very unexpected, but I have to say I accept on behalf of the entire JIS team. Thank you.
So we really want to thank you. You have supported us through thick and thin, and as I said, you make us look good. And now we come to the ceremony itself, where we firstly give thanks to those who participated in our opening ceremony. And we want to highlight the feature presentation by Dr. the Honorable Christopher Tufton. And we are also thankful for the continued support of our development partners. We thank Mr. Theodore Henry for his excellent role as Master of Ceremonies, to Dr. Nicole Dawkins-Wright for bringing greetings on behalf of our Chief Medical Officer. And we also want to acknowledge the contribution of Mr. Kerry Sales for his song selection, and Ms. Antoinette Aiken for sign language interpretation. We have to recognize a very important team, because without that team, we would not have had the ceremony a while ago where we recognize the awardees, and that is our judges. And our judges are so critical because they are sitting through 2 days of presentation. They are special to us, and they have become a part of the family. And so we want to recognize, firstly, our poster judges. And we ask them to stand. Mrs. Mullins has to direct me because I'm not exactly sure. But I will ask them to stand. Perhaps we can have picture taking at the end. So we have Miss Romaine Thorpe. Mrs. Nicole Martin Chen. Mr. Jovan Wigan. Mrs. Stephanie Bernard Stevens. Miss Prudence Hall. And Miss Lisa MacDonald. And to our oral judges, Mrs. Karen Nelson, Dr. Ian Campbell, Dr. Sharon Dawson, Dr. Shelley McFarlane, Dr. Patience Alonge, and Dr. Tamika Royal Thomas. And I also want to thank Dr. Alonge for your wonderful questions, because I think it helps us to generate discussion. Thank you so much. We also want to thank our hardworking secretariat, who has made this look so easy and effortless. But we know that it is not, and we know the work that it takes behind the scenes. And so we say a special thank you for those who helped with the magazine, the supplement, the agenda, the web page, public relations, the website, and Zoom registration and timekeeping. I would just invite our secretariat to stand. Actually, if the secretariat could come forward, I would appreciate it. And then we want to say a special thank you to someone who helps us year in, year out with our conference booklet and webpage development. Again, this is a surprise because he is not. They're asking for you to stand on the stage. Oh. Okay, so we're stopping for a picture opportunity. Dr. Webster, please come in the center. Thank you. Mm-hmm. Yeah. Mrs. Mullings. She's not? Please come beside Dr. Webster in the center. Center, please. Thank you. All right, thank you. Dr. Webster, please don't go too far, and Mr. Burrows, please don't go too far. I'll do it at the end, yeah, thanks. Yes, so in the midst of the picture taking, I was saying that there is a special person who helps us each year with our conference booklet and web page as well. And so we, after many years of doing this, and it really has been many years of doing this, we wish to thank and recognize Mr. Hector Burrows. Yes. They want you over here. Dr. Webster, don't go too far again, just one additional one. So it has been mentioned that there are many cogs in the wheel, and there is one person who pulls all of those cogs in the wheel together. And really, without that person, we would not be here. She is so integral to what has been done, and we want to express our appreciation to her. And I think that person knows who she is. But we really want to express our appreciation for excellent work and all that she puts into this to make the conference look easy. And so we want to recognize Mrs. Tennille Mullings. And last but not least, we would like to say a special thank you to our audience. But before we actually get there, I understand that our last researcher is here in terms of our research prize winner. So we just want to get that opportunity to recognize our research prize winner. So for the best student presentation and the most impactful poster presentation, we wish to recognize Dr. Pringle, Dr. A. Pringle, for her presentation entitled Intensive Care Capacity in Jamaica, a National Cross-Sectional Study. And Dr. Webster, please don't go too far again. We have a special recognition as our branch head and for supporting us through thick and thin. And so we want to recognize and to say thank you. All right, so we come back to say, last but not least, we want to say a special thank you to our audience for staying with us, for those who are still online at this time, and those who stood with us over the 3 conference days for faithfully supporting us over the event. This is a special year as we have 2 conferences in the calendar year, so please don't be confused. We have the 16th annual conference, which is from February 4 to 6, and we have the 17th annual conference, which will be in its usual place of November 18 to 20. So please mark it in your calendars. We thank you for your support, which has been overwhelming, and we ask that you support us once again. Please continue to join us as we celebrate research excellence. Thank you, and see you next time.